Ms. Carey.
Thank you, my lady. May I invite Dame Ruth May to be sworn, please?
I swear by Almighty God that the evidence that I shall give shall be the truth, the whole truth, and nothing but the truth.
Sorry, I just had to send a message. I've got the wrong notebook. Someone could go and get the right one. I'd be grateful.
Thank you. My lady, may I make a start on some background matters?
Do, please.
And we will
I can catch up.
remedy the notebook. Dame Ruth, your full name, please.
Ruth May.
You made a witness statement to the inquiry dated the 17th of May of this year, INQ 479043, and I hope you have a copy of that in front of you.
I do.
Right. A little bit of background about you, please. I think it's right that you've been a nurse since student days in 1985.
Yes.
You were made the Chief Nursing Officer in 2019.
Yes.
Until you retired in July of this year.
Yes.
Can I ask you, please, and if it helps you to refer to your statement, please do, just give us an overview of the role of the Chief Nursing Officer.
I was the former Chief Nursing Officer for England from January 19 to end of July. I was the most senior nurse in England. I led my profession, and I was the advisor to the government, to DHSC, and to the NHS on nursing.
I think you said there are currently around 386,000 nurses and midwives working for the NHS in England.
Yes.
And is it right that you do not line manage the nurses?
Absolutely.
I think you said in your statement that you have 3 categories really towards your work, and if it helps you, paragraph 17, Dame Ruth, you say you are accountable as an executive lead. Can you give us an example of what you did in that role?
Of course. So as a professional leader, I led on some of the national programmes. For example, international nurse recruitment, maternity, nosocomial transmission programmes.
You also say part of your role is to act as a collaborator. Again, an example of that, please.
I worked with my National Medical Director on the DNACPR. We worked to promote the practice on that.
Is that Sir Stephen Powis?
Yes.
Thank you. And you also have a role as a stakeholder or advisor. Again, an example of that, please.
Of course. So the Black Asian Minority Risk Assessment, I was an advisor to the CPO and to NERB, and my views I'm sure we'll come to.
Right. I think whilst you were the Chief Nursing Officer and during our relevant period for Module 3, you were supported by 4 Deputy CNOs, and there were Chief Nurses in each of the 7 regions in the NHS in England.
Yes, there were. There were regional chief nurses who had the responsibility and leadership to support the trust chief nurses, and they worked very much as part of my team CNO.
Thank you. I'd like to look at your responsibilities during the pandemic itself, and it may be that during the course of my questions to you, Dame Ruth, I'll ask the documents to be called up on screen. Before I do, and without causing you, I hope, any embarrassment, is it right that you have dyslexia?
Yes, I do.
Right. If I go too fast, or you want to take a moment to read through a document, please will you let us know?
Thank you.
So to the pandemic, please. You say at your paragraph 27 that you were the senior responsible officer for NHS England's IPC cell. Help us, please, what you did as the senior responsible officer in relation to that cell.
So the IPC, UK IPC cell was a consensus group. I was responsible for IPC in England. The group was made up of professionals, public health professionals, microbiologists, IPC nurses from across each country of the UK.
We heard yesterday from Dr. Ritchie, so we're a little bit familiar with the cell, and indeed we'll be hearing from Laura Imrie, who was also a member of the cell. Were you actually on the cell, though?
No, I wasn't. So my oversight came through, I met with Dr. Lisa Ritchie, Professor Mark Wilcox, the National Clinical Director for IPC, and my Deputy CNO with responsibility for this, almost on a daily basis during COVID, during the relevant period. Together with being a member of the hockey working group.
So just pause there, that's the Hospital Onset Commission Infection Working Group?
Indeed.
Thank you.
So together with being a member of that, I was being able to see and hear views from across the whole of UK. We were from public health specialists, microbiologists, and from infection control nurses. We relied as well on data, what the data was telling me. And I think finally my oversight was partly by membership of the senior clinical group as well.
I was going to come on to that.
Okay.
If I may. I think that was a group that was made up of who, please?
The senior clinical group was chaired in the early days always by the Chief Medical Officer of England, and then it rotated chair between the UK CMOs. It had Public Health England, senior doctors, Professor Harries, and then she went on to be the Chief Executive of AXA. Had the Public Health Senior Medical Advisor, Professor Susan Hopkins. It had the National Medical Director, Sir Stephen Paris, and it had all 4 UK countries, CNOs and CMOs.
Right. I think that group is sometimes known as the Senior Clinicians Group or Senior Clinical Group. And is it also known as the Senior Clinical Leads, or is that a different group?
I always knew it as the Senior Clinical Group, Clinicians Group.
And so that group of senior clinicians had oversight of the IPC cell?
The IPC cell was a consensus group. It was not a decision-making group. IPC members used to go back to their country, and their country then would make the decision. So, for example, in England, it would come to me and I would take a paper, often with the National Clinical Director, Professor Mark Wilcox, to our NERB, our decision-making group. But always, after each country had taken it back to their decision-making group, it would go to PHE or AXA for the final oversight of the content of any IPC guidance.
Pause there, so I want to be clear. The IPC cell make a recommendation. It is seen by you and or Mr Wilcox in relation to England, equivalents, I assume, in Wales, Scotland and Northern Ireland. Once it's been seen by those 4 nations, are you saying that PHE, AXA as it became, still had final say?
Absolutely, yes.
Right. So there's a number of levels of authority that it's got to go through before it ends up being published?
Absolutely.
If you and or Mr Wilcox said you didn't like a recommendation made by the UK IPC cell, what would happen practically?
So we would look at it, we would debate it. My role, of course, was around the operational implementation. So I had a view around how cohorting would work, how we would support staff in that. Then, of course, it would go to PHE and to AXA for the scientific sign-off of the guidance.
Right. So if you disagreed with the IPC cell, presumably you'd make your views known. Would you go back to the IPC cell and say, I don't think this is quite right, it's not going to work on the ground? How would it actually evolve?
So my role was to question, to challenge, to ask, have the IPC cell reviewed and considered the latest evidence, and I've done that a number of times during the relevant period, as all UK CNOs did. we all, collectively and individually, would always challenge and do that. But of course, the scientific advice came from the scientists. So public health doctors, I looked to the public health doctors a lot to give me that scientific advice, as well as the UK IPC cell. And of course, they had public health doctors within theirs, as well as other professionals.
Right. So if there's some, don't take this pejorative, backwards and forwards between you and the IPC cell, between the four nations, hopefully agreed position amongst all of you. But are you still saying that even if you all agreed, Public Health England and UXA, as it became, could still say, we don't think this is the right recommendation to make? We don't think this guidance is correct?
Absolutely.
Okay, all right. We may come back to that, Dame Ruth, in a moment. I think one of your other roles in relation to the pandemic was you were an executive, as an executive director of NHS England, you attended the Covid-19 National Incident Response Board. Help us, please, with what that board did.
It was often referred to as NERB. It was the decision-making group within NHS England. I was an executive director around there. I took almost 60 papers to that group during the relevant period.
I think you said they met 3 times a week or more.
Yes.
During that. You obviously engaged with your fellow CNOs in Wales and Scotland and Northern Ireland. And you said that there were 26 meetings just between March and May of 2020. You clearly worked with Chief Medical Officer, Sir Chris Whitty. You told us about the Senior Clinicians Group. You met with the Secretary of State, Mr. Hancock, and in due course, presumably Mr. Javid.
No, I didn't.
You didn't meet him. All right, thank you. You worked with PHE on IPC guidance. And one other aspect I'd like to ask you about is your engagement with frontline nurses. If it helps you, Dame Ruth, I'm at paragraph 54 in your statement. But I think there you said there was initially an informal advisory group, which then in due course became more formalised. Tell us about that transition.
Thank you. So we were facing some extraordinarily difficult decisions in the very early part of the inquiry. Difficult because it was a fast-moving environment, a time when we were seeing the number of cases come in, deaths that we hadn't seen like we'd seen before. So I wanted to check out the views of potential actions I was taking with some of the most very senior and experienced nurses. So I had a telephone book of probably the most forthright nurses in England at the time, and I chose them because I wanted them to give me their value of their experience, their expertise, but also they weren't going to say, yes, of course, you know. They were going to say, well, that won't work, that will work, have you thought about? And that really helped me and helped me make some tough recommendations and decisions.
You spoke there about your contacts with senior nurses. What about with those less senior on the front line?
Yes, so I had a shared decision-making councils that we set up in May 2020. And they were made up of frontline staff from all over England, of all sorts of backgrounds and settings. They reviewed what we were doing. I used to go to them with questions. I attended a lot of their meetings. And indeed, I'm seeing them tomorrow for my final meeting with them. I also, of course, visited, like I would do pre-pandemic and post-pandemic.
Yeah, I want to come on to the visits as a slightly separate topic. So you were having some input through the Shared Decision-Making Council from those on the front line, and in addition to your contacts with the more vociferous senior nurses that you've told us about. All right.
And with the Chief Nursing Officer, Black Asian Minority, Strategic Advisor, their SAG, they were invaluable colleagues.
I wanted to actually just ask you, please, about your involvement with the I think they're called CNO SAG. It's not a particularly attractive name. Just help us. What does that stand for, Dame Ruth?
The Black Minority Ethnic Chief Nursing Officer Strategic Advisory Group has been running now for 22 years. It's made up of people from a Black Asian minority background, nurses from all levels across the whole of England, and they are the most wonderful group to work with. They champion, they support each other, and they did some great work to support their colleagues and to support our national decision-making during the relevant period.
I think you say at paragraph 60 in your statement that thanks to the links through that group, you were involved in raising the issue of disproportionate impact of COVID on the Black, Asian and minority ethnic staff and indeed patients in April 2020. Can you just, perhaps by reference to paragraph 60, set out, please, some of the issues that came to your attention?
Yes, so they had held a number of teleconferences across all of the 7 regions with frontline staff. And it came through that they said that there were some people, particularly from a Filipino background and particularly women, that some of the masks weren't fitting properly because of the shape of faces were different. I took that, and my deputy CNO developed a program, an improvement program, to increase the number of types of masks. And indeed, there were 8 additional FFP3s available then for staff as a result of that program. That was where listening to frontline staff for me made a change in a national policy.
Although with that, the need to fit test another 8 different types of FFP3 mask. Can I ask you about this whilst dealing with this topic? Can you help? When did you first become aware that there was an issue of disproportionate infection and indeed death rates amongst Black, Asian and minority ethnic healthcare workers?
Yvonne Coghall, the then Res Director, emailed me, I think it was the 7th of April, I think it's in my statement here somewhere, but she emailed me raising that. I immediately talked that through with colleagues in the Strategic Incident team. And then the next day, I believe, we had a senior clinician meeting and I raised it with my senior clinical colleagues. And that is when the Chief Medical Officer for England commissioned some further work.
Yeah, well, we're going to be hearing from Sir Chris Whitty next week. May I ask you this, though? There's a lot of people that say they raised issues, they spoke about it with colleagues, they escalate it, to use a phrase that is often used. What practically do you think could be done to help minimise the disproportionate infection and indeed death rate on Black and minority ethnic healthcare workers?
So there was a risk assessment process that was established for making sure that workers from a Black, Asian minority background, from all backgrounds, not just nursing midwifery professions. It was led by the CPO Directorate, and you will know that I raised later, I think it was early June, that I wanted that risk assessment process sped up because I was hearing from, again, my colleagues from the Black Asian Minority Strategic Advisory Group that there were still people without a risk assessment. And I wanted that sped up.
We will turn to that a little later in your evidence. Aside from the strategic SAG group that you spoke about, was there any other way that you came to learn about issues and concerns faced by ethnic minority nurses?
The Jabali Network, which was a group of male men in nursing. It started off just literally before lockdown, 9th of March 2020. There was 9 of them, and now there's well over 100. They would give me feedback. And of course, I worked on the front line myself.
Taking all of those different sources of information, what would you say were the key issues and challenges being faced by Black and minority ethnic nurses and midwives?
It was tough for them. Tougher for them than people from my background. If I think back at the Nightingale, there were 30 patients, and all but one were from a Black Asian minority background. And that was replicated in critical care units. And then if you were staff treating patients that were also looking like you, that was tough for them, very tough. And so that's why we did a lot of work to support the associations. So this was the Filipino Nurses Association, the British Indian Nurses Association. There were 3 of them at the start of the pandemic, and I think now there's 36 of them. So we funded a small grant process to support them to do that. But it was tough for Black Asian minority nurses, particularly seeing so many patients from the same background.
You set out in your statement the work you've done with the Royal College of Nursing, the NMC, and like associations. I think you said in your statement that you didn't always necessarily see eye to eye with the Royal College of Nursing. Are you able to give us some examples of where you didn't agree with them and how that impacted either your response to the pandemic or indeed their response to the pandemic?
Thank you. So I had a very good relationship with Dame Donna Kinnair and then Pat Cullen, the chief executives during the relevant period. It was always a robust relationship, as it would be with any college/union. But we always had nurses and patients' interests at heart. So Dame Donna, particularly around PPE, and I were in conversation where they supported the guidance. But I knew that there were, particularly later into the pandemic, members within the RCN challenging some of the IPC guidance, for example. But at my level, chief exec level, we had a very robust and challenging but excellent relationship. And I'd say that the same with Pat Cullen.
In relation to IPC, would that be around the provision or otherwise of FFP3 masks?
Yes, and indeed, the beginning, it was around gowns and aprons.
Fine. We're going to come on to look at some of these specific issues with PPE supply. Finally, you've alluded a number of times already to your work on the front line, and I think in your statement you say you worked during our relevant period on wards on 29 occasions and indeed undertook a number of visits of different wards, including critical care units. Help us, please, on any or all of those occasions. What was it like?
An utter privilege. Excuse me.
It's all right.
Have a quick drink of water.
Please do.
Take your time.
Thank you, my lady. It was an utter privilege. It really was a privilege to be a nurse.
What did you see? Tell us, Dame Ruth. Give us a little insight into what
Yes, of course. So early on, I did 2 shifts at the Nightingale. The first time I've already referenced. The second time was literally on the way back from my stepmother's funeral in Wales. I then did an evening shift. And I actually nursed to nurse, which was a privilege to do.
I worked, I visited inclusion nurses, nurses that work in homeless. I visited a care home. I had the great privilege in December and January to work in the vaccine programme. That gave me hope. But I also worked in ITU on a Sunday morning. Under the radar, worked alongside colleagues. There was death. There was death. There weren't visitors. Nursing ratios were stretched. But it was very powerful because I was able to go back then to Matt Hancock, to the Secretary of State, and go, this is what my recommendation is. No, we're not doing that. Yes, we are doing that. So it gave me a real live experience of what it was like to wear full PPE. And Dame Donna was with me on the first time in Nightingale, but nurses were at the brunt of this.
What was it like wearing full PPE from a practical perspective?
Oh, yeah. I was a theatre nurse by background, so we were used to wearing masks, but not FFP3, of course. I was fit tested at the Nightingale, but I was fit checking every shift I did when I was at Colchester, going into working alongside colleagues at critical care. They gave lots of nurses, including myself, indents into our cheeks. But they were the protection that was needed for critical care units. But it wasn't just the mask. It was the eye protection, the gown, the glove. It frankly took ages to get everything on and off.
We might come back to that in a moment. Can I change topic?
Of course.
I'd like to ask you, please, about pre-pandemic work issues. And Dame Ruth, if it helps you, I'm in paragraph 88 in your statement.
Yes.
And I think you say this: as at December 2018, there were workforce vacancies in the NHS in England alone of 39,686 nursing and midwifery vacancies. Call it 40,000 just for ease. There was some increased funding given, is that right, to provide 5,000 additional places for student nurses?
Can I ask your permission to provide a bit of context before we get to that?
Of course you can.
So, you're right, there was very nearly 40,000 vacancies. In England, which is different to the other devolved nations, the bursary was removed.
Is that a student bursary or a...
So,
helps with that?
in 2017 or 2015, the then George Osborne Chancellor announced that they would get rid of the student bursary, which is in effect the student fees were paid for and a maintenance grant, which meant that there was a significant drop, indeed a 23% drop in nursing and midwifery applications as a result of that. So instead of nurses being trained, like I was, like many other nurses were, when we received free education and a maintenance grant, nurses and midwives now as students, well, at that period, were not receiving that. So they ended up in a lot of debt. That meant, and HEE colleagues have done some analysis of that work.
Is that health education?
Health Education England. They've done some analysis of that work, and it meant that we were 5,000 fewer nurses in March 2020 because of that decision, and 700 fewer midwives in March 2020.
So you have a general deficit in 2018, but come the start of the pandemic, a significant number of fewer nurses and midwives.
5,000.
5,000.
5,000 fewer nurses at the beginning of the pandemic because of the bursary decision.
Can you help us? How does that play out on the ground? If you had 5,000 more, maybe another way, how many extra nurses would there be in a hospital?
I reckon it would be about around 40 extra nurses in each hospital. Now, of course, hospitals are different sizes. That, I think, would have made a difference. Maybe we needn't have made some of the decisions around critical care ratios. And of course, if we had more nurses, there'd be less burnout. There'd be less psychological impact. Removing the bursary, for me, was a catastrophic decision.
All right. Let's look at a programme in 2019, I think, launched by the Department of Health and Social Care to deliver 50,000 nurses by 2024 and 2025. Now, basically. Is that new recruits, or getting people who are off the register back, or international recruits, or increasing students? How are they going to make up the 50,000 nurses as part of this plan?
So just before that, of course, we had the £5,000 maintenance grant that I championed and the government supported. Indeed, Matt Hancock supported that coming in place, which was a support to attract nurses, and that did work. But it wasn't still free education. But going on to your point, the DHSE launched the 50,000 programme, and it was 50,000 extra. So, of course, we had to recruit and retain more than the 50,000 in order to allow for people leaving and retiring. I was responsible for international nurse recruitment, and at the time we had an aim to deliver 18,000. Of course, we completely exceeded that, and we'll no doubt come to it. And HE colleagues at the time had a role to increase domestic nursing supply with the aim to get to 19,000, and the CPO nursing retention was 13,000. So that 50,000 was broken down into international nurse recruitment, domestic supply, and retention.
Can I ask you this? I think there were projections for between 20 and 30% staff absence in England alone during the pandemic. Does that mean on any given day or week it would be predicted that there'd be up to a third almost of nursing staff missing? Or is that too simplistic a way of looking at it?
So the way I recall it was the strategic EPRR director, Professor Sir Keith Willett, wrote out to myself and to Steve Powers and said, we're going to be 20 to 30% short. It was because that was the formula that as part of the pre-pandemic planning. I think that's where it came from. So increasing workforce supply was a key action for me.
Right. I want to, maybe I've not made myself clear. You're going into the pandemic with a deficit of nurses and midwives. Then there is the impact of the pandemic, so nurses getting sick themselves or isolating, which could cause a 20 to 30% absence rate. The 50,000, was that meant to cover the pre-pandemic deficit and or the absences caused by the pandemic itself?
The pre-pandemic.
Right.
And the 50,000 programme was a step towards the vacancies. My recollection was in modelling, it should have probably been an 85,000 programme. but it was a £50,000 ambition that the government set.
And what happened?
We delivered 64,000 additional nurses.
So I'm not following. You spent some time, and there, as you'll understand, there's a limit to how much I can go into austerity measures and party politics and the like.
Of course.
And who decided to introduce fees for education and things. But you did say that you blamed the withdrawal of the bursary for the fact that there were fewer nurses, but now you said that the programme recruited 64,000 additional nurses, so I'm not quite following.
So we went into the pandemic with nearly 40,000 vacancies. We would have had an additional 5,000 vacancies at the start of the pandemic if the bursary hadn't been removed. The 50,000 ambition came because nurses were going to carry on increasing in need and demand. So the government decided to have a 50,000 ambition. I supported that. We actually delivered by November 23, with using September 23's data, we delivered 64,000 additional nurses. So at the start of the pandemic, September 19, the programme was launched. We worked hard to increase the number of nurses, and even harder throughout the pandemic to make sure that we over-delivered against that.
Thank you. Was just briefly asked you about staff absences. Can I just ask you about long COVID absences in nursing? If it helps you, further on in your statement at paragraph 219A, but I think you attended a meeting, certainly in December of 2021, looking at the issue in relation to long COVID absences and the impact it might have on nursing. Can you just summarise what you learned at that meeting, and indeed what was your takeaway in relation to the impact of long COVID on the nursing profession?
I believe this was the round table chaired by Lord Bethell.
It was.
My medical director colleagues, Nikki Kanani, Kathy Hassel, they presented a paper on long COVID to the Minister with what they were doing on that. I took away from that meeting and others that we needed to support nurses supporting patients with long COVID, and that's why we developed a framework to do that, to support them.
Oh, and in a nutshell, what did the framework achieve or set out to achieve?
It set out to support nurses because this was new. It involved multi-professional working and nurses from all sorts of clinical backgrounds. There were I received some advice from Dr. Elaine Maxwell, who was very helpful in this area, and we got experienced people that were through life were experiencing long COVID to support that framework development by one of my deputy CNOs.
Can you give us a practical example of support, perhaps not provided by you, but through the Chief Nursing Officer Directorate, how practically you supported people with long COVID?
Well, people with long COVID, there were often nurses that had long COVID. Most of the support for that came from how we supported them with their pay, their terms and conditions, how we got them back to work in a part-time capacity, in a very different capacity. I met one of the long COVID nurses on a Teams call that was describing how she's now doing part-time research and part-time in her old job, so that it supported her back to her full health.
Looked there briefly at some of the issues going into the pandemic and some attempts to increase nursing capacity. But can I ask you about 4 specific ways that nursing capacity was increasing? Can we call onto screen, please, 421158 at page 2. If it helps you, Dame Ruth, it's in tab 2 of the bundle, but it might be easier just to use the screen. And this was a letter that you wrote on the 6th of April from you and indeed the Chief Nursing Officers of all 4 nations, I think, outlining the 4 ways that it was intended to increase nursing capacity. The first one there is once the government has passed the legislation, thank you, to enable the NMC, the regulator, to establish a COVID-19 temporary register is our first focus. We'll be inviting those who've left the register within the last 3 years to opt in should they wish to do so. All right, so to get people who've come off the register in the last 3 years back onto the register, why was the 3 years chosen?
Because it could give us a potential 50,000 people. The NMC looked at the data and said that they thought it was 3 years would be the right number of years. UK CNOs debated that and agreed, and so it was 3 years. Later on, we did longer.
Thank you. I'm going to come on to that, but I think you said it was anticipated that if you went back 3 years, the NMC that thought it might give you a cohort of around 60,000.
In the UK and
51,000.
51,000.
All right, so that could potentially fill the gap.
Yes.
All right. It was aimed, I think you say, at people under 65 who are perhaps now working in different areas of the healthcare market. You widened that, though, as I understand it, to cover people who left the register within the last 4 to 5 years. Why was it widened from 3 to the 4 to 5?
Because the picture we were facing with COVID and the number of patients coming into hospital was increasing at a further rate. So we needed to take further action.
Was it thought that those who'd left within 3 years would effectively be more up to date with their skills, if I can put it like that, than those perhaps when 4 or 5 years has lapsed?
Indeed.
Right. But notwithstanding that, the need was such that you needed to go back 4 to 5 years. All right. Now, whether it was 3 years off the register or 4 to 5, can you help us with what plans were put in place to ensure that those who were returning were sufficiently skilled and up to date?
So each of the trusts where people went, nurses went, they did an induction programme, they did some key skills training. But it depends on where they were. So I worked alongside some children's intensive care nurses. Of course, they've got very real and very transferable skills. I also worked alongside some people that had been in education and not been on the register but wanted to support. They needed more of those skills. But of course, we were in the middle of a global health emergency. We weren't going to be able to provide an induction programme over 12 weeks that you would potentially provide in peacetime. This was unprecedented times.
Now, I think expressions of interest from those who were potentially returning did not always equate to staff actually being employed. Can we have a look at that, please? And can I ask that it was put up on screen 421170.
Which tab?
It is in tab. I've got the wrong note, but we'll put it on the screen and we'll just work off the screen. Now, this is a very long email
yes.
setting out the returners. And can we go to page 68, which is position at the beginning, and as you go through an email, inevitably we end up at where we need to be.
Yep, I've got it.
Bottom of the page there, this is the position very early on, just as we're about to go into lockdown. As at 11:30 a.m. on Saturday the 21st of March, the NMC had received nearly 4,000 applications to join.
Yes.
Can we just go to page 67? Day later, it's gone up to 5,633 applications. And I'm going to jump forward a month to page 4, if I may, please.
Yes.
It's just coming on screen now.
Yep.
Set out in a slightly different format with more detail, but here we are 1 month on from the nearly 4,000, and now we can see the NMC confirm there is nearly 12,000 nurses and midwives across the UK on its temporary register. And the data has now been broken down into midwife nurses, into which country, and indeed which age bracket they're in.
So the NMC set this up very quickly, and we appreciated that by the UK CNOs. And of course, we understood that it was UK data to begin with, but as soon as they could, they broke it down, as you can see.
If we go to page 3, there is an email, I think, from you at the top. Great to have nearly 12,000 back on the register. How many of these have done their first shift? And that really brings me on to the point that just because you went up back on the register did not necessarily result in people on the ground.
Absolutely, and I was corrected by Scott in my team quite rightly, because that was the UK figure, and the England figure, as he then further goes on, was less. But that was my first time going, it's all very well having them on the register, temporary register.
But what next? So let's look at page 2 of the document, please. Yep. And there's an email from Scott Binion.
Yes.
Setting out, just for England, you've got 9,841 opting to the temporary register.
Yes.
Of whom 8,950 are passed to the regions for deployment. Deployed by regions to the front line, we go from 8,950 to 2,785. Can you help with the decreasing numbers that we see set out in that table? We'll leave 111 for a moment, but how come is it that there's a lot of people looking to join the register, but when we get to deployed to the regions, by regions to front line, it's 2,785?
I think this is one of the areas of learning for us. This was an issue that all 4 countries experienced. There was a lack of capacity within our regional BBS, bring back staff teams, because they had a lot of people interested. Now, where it worked well was when critical care nurse had just left 3 years ago, 2-3 years ago, in their local unit, and they still had a relationship with them, and they rang them up. That's when it worked very well. Interestingly, though, the NMC does hold data on their branch of nursing, whether it's paediatric, mental health, adult, but doesn't hold data on their specialism. So doesn't have a data about, these amount of anaesthetic nurses, theatre nurses, critical care nurses, A&E nurses. And if we'd had that, I think we would have been able to concentrate on those first.
Yep.
And then maybe we wouldn't have seen the lack of BBS regional capacity like we did. So the bottlenecks, there was pre-employment check bottlenecks, and there was also a difference between what returners by then are wanting to do. When we got to wave 2, of course, though, a lot of these people went into the vaccine programme. And I'm grateful for everybody that came back to help us. And I think what my email does show is there was a lack of data on deployment.
Well, you also make the point there in the Scott makes the point in the bottom bullet point that 15 to 20% of those that opted in to temporary register withdrew from the process prior to deployment. Regions are working through this, but there are a number of reasons. Changes in circumstances, for example, people self-isolating, individuals not wanting to work on the front line, and then there was the pre-employment checks and individuals not returning their contract. A multitude of reasons as to why initial interest did not always translate to nursing in the wards.
Yep.
All right. Can I just ask you this? Is there any merit in always having a temporary register, do you think?
The NMC does not have the legislative ability to set up a temporary register, whereas the GMC do. It is part of the legislative reforms that are being considered. But yes, that is something that they do need the ability to have.
In short, if there needs to be a temporary register for whatever reason, there's got to be legislation passed to deal with the NMC aspect of it, whereas the GMC already have a ready-made legislative power to do it.
Yes.
All right, okay. Can I go back, please, to 421158 and look very briefly, if we may, Dame Ruth, at the two other ways of increasing capacity? We've just got to revert back to a different document, or it's in your tab too, if it helps you. Thank you very much. Second way to increase capacity was encouraging those skilled who are currently on the register but not working in clinical care to come into clinical practice. Who was this aimed at?
It was aimed at the many staff that were in organisations. So there were people in governance teams that are a nurse by background that could support. It was aimed at people in our ALBs, in my own directorate, in Health Education England directorate. It was aimed at those people that were still on the register that could provide support.
Thank you. The third way was changing the nature of the programme from undergraduate nursing and midwifery students of the last 6 months of their programme, so they may be delivered in a clinical placement. I think it's a 3-year degree for nursing,
Yes,
is that
it
right?
is.
And so just help us, what was the plan in relation to the students in the last 6 months of their programme? If it helps you, I'm at about paragraph 116 in your statement, Dame Ruth.
That would be very helpful, thank you. 116.
I think you say there the NMC requires 2,300 hours of academic study
Yes.
and 2,300 hours of supervised practice-based learning for those student nurses, is that right, and midwives?
Yes, so for students, they needed to be supernumerary. They're
What's that?
supervised, they're not in the numbers. They are there to learn. They are learners. Of course, we then needed to change the standards, the educational standards for these learners, for these students, to be able to be working in critical care, therefore without their supernumerary status. But we wanted their work to be able to be counted towards their educational studies. So the NMC needed to do that, and they worked very, very supportive of us, and they needed to do that across the whole of the 4 countries. This wasn't something that could just be done for England, and that's why working with my team, my CNO colleagues, was so important.
I think you said in your statement that it had been identified that there were 18,700
Yes.
nursing students in their final 6 months, so potentially nearly 19,000 nurses that could start helping out. Is that across England or the UK?
That is across England, but I need to make a correction because that is nursing and midwifery.
Okay, thank you.
So it was 16,547 for nurses and 2,175 for midwives, and together that made 18,700.
Can I ask you this about the student nurses and midwives, though? They're finishing their academic studies, they're doing their practical supervised learning. Did you receive any feedback about how young nurses and midwives coped when they were deployed onto the front line? It just seems, if I may put it like this, a baptism of fire. What did you do, or how did the CNO try and help cater for that specific cohort of nurses and midwives?
So this was, again, one of those tough decisions that, again, I took to my strategic advisory group, this group of very senior experienced nurses, and none of us wanted to do this. We wanted to continue their education, but we're in such a position that we needed to increase workforce numbers. So we made the decision collectively, we debated it. We wouldn't do first years because they were literally only just out on placement in the January. We wouldn't do third years in the first, we'd only do them in the very last cohort. Now, the last part of their training. It was not mandatory to do, though. It was a choice by which people were able to make. And people did make that choice, not to go onto the front line, and we respected them to do that. The second years, though, we wanted to continue as much as we could, so they still had one day in their university to keep them linked in. There were risk assessments, but this was not an easy decision. But student nurses were amazing support. And their feedback, and the 7-point plan review fed back. There's lots of surveys that the Health Education England colleagues did at the time, fed back what more support we needed to do. That's one of the things the RCN wanted us to do, which we did do, which is make sure they got sick pay. So it was difficult, but they were amazing.
I'm not going to ask you about the temporary register at point 4. Can I just briefly touch on international recruitment? I think you said in your paragraph 141 that the process of recruiting internationally is not new. It's been a long-established process within the NHS. But in reality, given the lockdowns, was it possible to boost the nursing numbers by international recruitment during the pandemic?
Yes, it was.
How did that happen?
Through a lot of hard work by a lot of directors of nursing and colleagues in the teams. We were recruiting between 5,000 and 6,000 international nurses anyway. And we've welcomed international nurses since the very beginning of the NHS, with the Windrush generation, with Philippine and Indian nurses back in the early 2000s, and then this big recruitment campaign. But of course, restrictions like global travel affected everybody. So there were times, particularly at the beginning, that early summer, when nobody was travelling. So even those people that were due to come weren't able to come, they were delayed. Then, of course, there were the closing of the OSCE centres, which was the clinical training centres.
So that meant that international nurses couldn't go through the requisite training to ensure they had the same standards as applied in the UK, is that right? Or in England?
So in the UK, they could go through the training, but they couldn't go through the assessments. And that was, so in peace times, what happens, and now, an international nurse would come over, they're internationally educated, they're trained in their own country, they then have to go through an OSCE assessment of their clinical skills in order for them to go onto the permanent register. With the OSCE centres closed, and they didn't open until July 2020, we would have to use these international nurses in a different way, and that's why we came up with a temporary register with them as well.
Would a number of the international nurses be from a black and ethnic minority background?
Yes.
Given that we know that they were disproportionately impacted, was there any thought given to whether it was the right thing to do to ask black and minority ethnic nurses to come to the UK and potentially face the consequences of a disproportionate impact on them? Was any thought given to that?
Yes, of course. So in wave 1, they were here. In wave 2, of course, as we were headed towards the winter of 2020, by that stage, all black Asian minority nurses had had a risk assessment, and some had been removed from clinical frontline care. So, yes, of course.
Okay. Can I deal with one other topic, please, perhaps before we take a break, if I may, and it's in relation to redeployment. And can I ask you, please, Dame Ruth, to turn to paragraph 166 in your statement. And in particular, I'd like to examine redeployment to critical care and changes to patient and nurse ratios. And you've already referred to that.
Which paragraph? Sorry.
Probably easier, actually, just to go straight to paragraph 171.
171. Thank you.
And if we could have on screen, please, INQ 421-219 0005 as the page reference. Thank you very much. can you just help us in non-pandemic times, in critical care, what should be the nursing to patient ratio?
Critical care has patients on a ventilator needing high level of intervention and with highly skilled staff. So always, 24 hours a day, there is a trained critical care nurse. And let me just spend half a minute and tell you what that is, because
How is that different from I don't mean an ordinary nurse, but you understand there's a distinction.
So I'm a registered nurse, like many, many thousands of other nurses. I have had experience and a qualification post my registration in theatre nursing, which meant I was a trained theatre nurse. It's the same with critical care. These are registered nurses, all with some experience, and many of them many years' experience, but all trained in additional level of skill and expertise, all with an additional qualification. So these are true experts.
And they tend to the sickest patients, if I can put it like that, in theory, one-to-one in non-pandemic times.
Yes, and obviously with medical colleagues, part of a multi-professional team, with the pharmacist, the physio, and other colleagues.
During the pandemic, however, was there a decision taken to change the patient to nursing ratios?
Yes.
And who made that decision, please?
All 4 countries made that decision, and for us, the decision formally was made by NERB.
By NERB, the National Incident Response Board.
Yes.
Is that right? Were you part of the decision-making process?
I led it.
Right.
So,
Can I ask you then, how is it that you came to take the decision that in some cases we may need to go from 1 critical care nurse to 6 patients?
yes, so Sunday, 22nd of March was a day that I will never forget. Started off at 9 o'clock in the morning when we had our meetings, and I was being told that we've got 4,000 critical care beds in England, but in 16 days' time we're going to need 7,000. But I had a meeting at 1:30 actually on the Sunday with the British Association of Critical Care Nurses, Nikki Credland as chair, excellent critical care nurse leader, and one of my deputy CNOs, and of course with some other critical care nursing experts. And they'd been doing some great work, this work. They'd been talking to colleagues from across the UK and other colleagues within their profession that this could be a proposal to take that forward. A team approach. Not ideal at all. And I know there's been consequences because of it.
Let me pause you there. It's not 1 to 6, maybe slightly misleading, because as you can see there are other staff as well performing roles. You've got staff A, staff B, but they are not those with critical care training skills, are they?
No, staff A are nurses with recent or past critical care experience, and staff B are nurses with no critical care experience, and staff C are with healthcare support workers. So it was much more of a team. So I worked as a staff B, and I was on a 1-to-2 ratio at that time, working in my local hospital. And it didn't feel like a 1-to-2 at all, because when somebody went for a break, it wasn't a quick cup of tea and back. It was taking all the PPE off and back on again. So it was a 45-minute experience. So it actually felt like 1-to-3. And that's why in wave 2, we didn't do this. We did this in...
Before we come to wave 2, what happened then when the one critical care nurse who's looking after 2, 3 or 4 patients needs to take a quick comfort break? Who was there to fill the gap?
There was always a 1 to 4. There was people that would cover for each other. But there were occasions when there were 1 nurse to 6 patients, 1 critical care nurse to 6 patients. There were other professionals. This is a decision that will stay with me forever.
Dame Ruth, do you think that the diluted staff ratios affected the care that those patients received?
Yes.
What about the impact on the critical care nurse themselves? Inevitable impact on them, I assume.
Inevitable. And what we now know with Kevin Fong's work, for example, and that's why we launched the Professional Nurse Advocate Programme for critical care. But yeah, this was not where we wanted to go.
Why did you do it? Why did you make that decision then?
Critical care capacity was doubling, trebling, quadrupling, 10 times the capacity in other places. We were seeing reports in Italy where patients weren't able to get into hospital. Yeah.
You mentioned, and perhaps we'll pause then after that, if we may, my lady. You said we didn't do it in wave 2. Why not?
Because 30th of July 2020, Professor Kevin Fong's briefing shared with me the impact that it was mainly having on nurses. So we developed the Professional Nurse Advocate Programme, we developed a whole range of practitioner health, but I made the decision then that we're not doing this again. But it was a critical care shift that I did in January 21, a Sunday morning, and I had my regular meeting with the Secretary of State, Matt Hancock, at the time the next day. And of course, there's the pressure of getting on with the electives again. And he said to me, why can't we do 1 to 3 ratio all the time? And I said, no. I was there yesterday morning and I explained to him what it was like. He backed me and we did maximum of 1 to 2 during the next wave.
All right. My lady, would that be a convenient moment?
Certainly. I hope you're warned that we take regular breaks.
Thank you.
You might welcome one as well. I shall return at 25 past.
Thank you very much.
All rise.
carried.
Thank you, my lady. Dame Ruth, can we turn, please, to a different topic, and that of the IPC guidance? And it starts in your statement at paragraph 230 onwards. I think you were the National Director of IPC for NHS England, is that right?
Yes.
And as you told us, you were the co-chair of the Hospital Onset COVID Working Group.
Yes.
And you say in your statement you have national responsibility for NHS England's Covid-19 Nosocomial infections programme.
Yes.
Turning to the guidance itself, at paragraph 232, you say that NHS England's role in the guidance was through the membership of the cell. You brought together the leads and specialists from across the UK. Initially, the cell provided comments on draft guidance, but from June 2020 onwards, the UK IPC cell drafted the guidance. Right. And as I think, if I've understood your evidence from this morning correctly, you would then see that guidance and have the opportunity to comment on it, agree, disagree, amend as you saw fit.
Yes, and indeed the draft guidance would go back to each of the countries for their equivalents and their public health and their leaders to consider as well, before it then went to PHE for final approval.
I think you say in your statement that you don't have specific scientific and technical expertise, and you say it's not my role to make decisions on issues such as PPE specification and the use and types of disinfectant to use. I just want to be clear what you mean by that. When you say you didn't make decisions on PPE specification, what did you mean there?
I mean that the scientists provided me and across the UK the advice on the scientific elements of the IPC guidance, of which that was it. For my role was much more about providing executive leadership, supporting the conversation, supporting the coming together of UK-wide discussions as part of UK-wide CNO discussions, supporting, for example, the National Clinical Director, Professor Mark Wilcox, when I was going with him to the senior clinical group, and indeed supporting Dr. Valerie Davies, the microbiologist, the public health doctor in Wales,
Yes.
when she presented the consensus statement in late 2021.
All right, but she in due course, I think, became the chair of the
She
IPC
did,
cell after
the
Dr.
second
Richard.
year.
I just want to be clear, was it part of your remit to say, I don't agree that it should only be FRSM, I think it should be FFP3?
My remit was to challenge, to ensure that the scientists have taken the latest evidence. And the scientists were the public health doctors and the UK IPC cell, which had a range of professionals within it from across the UK.
So if you thought that a wrong decision had been made about the level of masks, for example, that should be worn...
I would question it.
Right. And then it would go back to the cell for their view?
And indeed questioned Dr. Susan Hopkins, Professor Susan Hopkins and Jenny. Jenny and I and Susan and I had many a conversation, as did the National Medical Director, Steve Paris, with Susan and Jenny. And Chris Whitty.
Sorry, I didn't mean to interrupt you.
Sorry, I apologise.
Were you familiar with the different modes of transmission of this respiratory virus? Contact, airborne, droplet?
Yes.
Are you a scientist by background, familiar with the physics and engineering and droplet sizes?
No, I am absolutely not. I needed to rely on public health specialists and other specialists.
Can you help us, at the beginning of the pandemic, what did you understand to be the mode or modes of transmission of COVID?
I understood it, like the World Health Organization was advising at the time, to be mainly droplet, but of course with aerosol, particularly then, that's why we had the guidance for AGPs, so that we supported, it was making sure that we had guidance for aerosol generating procedures. But at that time, all of the guidance, all the advice, scientific advice, was predominantly droplet.
Do you accept that on the back of the scientific advice, consequential decisions are made about what IPC measures should be put in place?
Yes.
All right. And so droplet goes down one or a number of routes for IPC. Aerosol and airborne transmission may require different IPC measures. In general, do you agree with that?
In general, IPC measures are a combination is not just around masks. Masks are very, very, very important, but so is distance in between beds, so is eye contact, eyewear, gowns, gloves, a whole range of measures.
Did you gain an understanding as the pandemic progressed that aerosol transmission played a larger part in the way that the virus spread?
Yes.
Can I ask you, please, about December 2020? We heard from Dr. Ritchie yesterday, it's not in your statement, that Public Health England were telling the IPC cell that they thought that their understanding about aerosol transmission had changed and there was a bigger role that aerosol transmission was playing. And Public Health England recommended a move to FFP3 masks on a precautionary basis. Now, that was not the position the IPC cell came to on a consensus basis. But Dr. Ritchie told us that there was a paper produced and that you and the senior leaders saw the paper. So can I ask you about that, please? Do you remember being made aware that Public Health England had come to a changed view about the role that aerosol transmission had played?
I remember that the Public Health England member of the IPC cell had come to a potentially different view. I'm also aware of UK colleagues from public health backgrounds had a different view. There was a consensus. Now, I'm also aware that because of a differing view, I wanted to make sure we belt and braces, and that first statement was agreed by the most senior medical scientific advisor in PHE/UXA.
When you say that first statement, what do you mean there, Dame Ruth?
That statement you're talking about then.
That their understanding had changed?
Yes. The consensus statement end of 2021, I'm sure we'll come on to later. But
so
could you just complete?
Yes. Let me deal with it. You became aware then that PHE's understanding had changed. You were aware that the consensus cell had come to a slightly different view on a. It was raised with you, I think you said you agreed with. Did you agree with the decision of the IPC cell?
I took assurance that there was a debate. I was actually pleased there was a debate. I didn't want groupthink. I wanted to know that people had the confidence to debate the merits of the evidence and the merits of potential action. So in terms of process, for me, that was good. I took assurance that there are other colleagues across the UK from all sorts of professional backgrounds that had a differing view. But I also wanted to make sure that PHE's more senior doctors, I wanted to know their views.
Right.
And we did have their view.
Pause there. The question I asked you is, did you agree with the decision of the UK IPC cell?
Yes.
So
Even though you said you were concerned about having, sorry to interrupt,
Not at all.
belt and braces.
Yes, because my role has always been to challenge, to ensure that everybody's looking at the evidence that has got the scientific evidence, scientific background.
But surely a belt and braces, or what I think some have been calling the precautionary principle, would involve going down the path recommended by the Public Health England member who said FFP3 masks. Wouldn't that be belt and braces?
I think at that time there was nobody other than, as you said, my lady, saying there was evidence for FFP3s all of the time. What I also know was I wanted to seek PHE's most senior doctor's view of whether the guidance needed to be changed on FFP3. And we did that. And the view was we didn't need to change it.
You say that you rightly wanted to avoid groupthink, and as you may know, it's something I reported on in Module 1. Did you ever consider that there might have been an element of groupthink when it came to the mode of transmission? That the groupthink, including the World Health Organization, was the mode of transmission was droplet?
I don't think we did, because there was the World Health Organization, there was the UK IPC cell, like we know, it's got lots of people involved with very technical and scientific expertise. There was the senior clinical meeting with every UK CMO, CNO, AXA chief exec, the senior medical, plus some of the other deputies in there. There were so many people in so many different groups. There was the hockey working group as well, with another range of people. So there were so many different groups saying that. And even today, as I understand it, World Health Organization hasn't come out and said it's predominantly aerosol.
Melody, may I just finish this topic in this way? When you came to learn that Public Health England had a changed understanding of the route of transmission, did you speak to anyone in Public Health England about that and what underpinned that change in understanding?
Can I just check for clarity? It was that December 20.
Yes, it is. 22nd and 23rd of December 2020.
Yeah. There is email correspondence. I recall it was Mark Wilcox talking to Susan, but I also know my National Medical Director spoke to PHE colleagues. I can't recall whether that was Susan or Jenny, so I apologise.
Did you speak to any PHE colleagues?
I don't think I did, but I can't recall.
Right, fine. And what about Sir Chris Whitty? Did you speak to him and say, well, PHE have got a slightly different view here, Sir Chris, let's discuss the merits or otherwise of it?
I think we discussed it at a senior clinical meeting, which Chris was chairing. I'm absolutely sure we did.
Yeah, I know. They haven't said that. They've said it. Thank you. All right. Can we look at some of the specifics in relation to PPE itself? Now, you are not responsible for the supply of PPE. You make that clear in your statement. But I think you say in that statement at paragraph 252, Dame Ruth, that you became aware of supply issues. And can you just help us? How did you become aware of problems with PPE supply?
Oh, numerous ways. From regional chief nurses feeding back, from the UK IPC cell feeding back, and indeed the first time I became aware was the 16th of March when the then head of IPC, Linda Dempster, told me and my deputy CNO that there were PPE supply challenges. From the incident, strategic fusions, when their feedback from the EPR colleagues, from me going to talk to care home colleagues, from me, there were PPE from the RCN, Dame Donna, yeah.
A number of different sources there.
Yeah.
I think you make clear you were not involved in the decision to declassify COVID as a high consequence infectious disease. Obviously, you're aware that it was classified and then declassified. And you were not involved in the decision for IPC guidance to recommend FFP3 masks only in intensive care and or when AGPs are carried out. All right, but you're aware that that's the background and where we end up, essentially, by about the 6th or the 13th of March 2020. Okay.
Yes.
Were you concerned that recommending only FRSM to the vast majority of healthcare workers in the guidance in March 2020 did not sufficiently protect those healthcare workers?
I think I was more concerned at the time about supply, because that's what was being fed back to me all of the time. So if I think back to, I think it was the 3rd of April 2020, when I had a webinar with my National Medical Director, Sir Stephen Paris, with medical directors, chief nurses on the webinar. Susan Hopkins very helpfully came to present the tables guidance. It was all about supply, it wasn't about the guidance. So the main concern that was coming into me was supply.
All right, well, let's look at that supply issue, because I think you say that there were concerns about supply through March and April 2020. There were increasing reports from frontline staff of PPE shortages. Concerns were discussed at the senior clinicians group on the 9th of April. And a pinch point effectively coming here around 12th, 13th of April. So I'd like just to focus on that, please, for a moment. Is the position this, that there was a discussion regarding gown use amongst the senior clinicians and indeed a number of the people that you've spoken about? Can we have a look on screen, please, at INQ 477782? And it's behind tab 13, Dame Ruth, but it might just be easier to look here. Here we are, 12th of April, an email to you from Dame Donna Kinnair of the RCN. She's had a discussion with you, wants to confirm my discussion with you that the RCN and you as our CNO would not support sending nurses or healthcare assistants to look after patients without the appropriate PPE equipment as determined by the WHO guidance and the recent guidance that we supported that PHE issued on the 10th of April. Whilst we recognise that PPE gowns are in short supply with the possibility of us running out, our stance would be that sending nurses to look after patients without appropriate protection is a failure of our duty of care to them as individuals and in breach of health and safety legislation. Issue was with gowns, clearly. Do you know why there was an insufficient supply of gowns?
Yes. The pre-pandemic planning stockpiles did not include gowns. And that left us extremely short. It was a very stressful time. It was Easter weekend, and Donna and I spoke more times than I spoke to my family, and she spoke to her family. We were completely aligned that we needed to concentrate on getting more gowns and not moving to aprons, because that wouldn't protect nurses in the way we felt they needed to be protected.
I think the IPC cell in due course, and certainly the guidance, recommended what's called sessional use.
Yes.
And reuse. Can you just help us? What is sessional use, please?
When you use it for a session, so you use it for the time you're in caring for patients. So I, for example, when I used it, and Donna actually, when we did it in Nightingale and indeed in my other ships, you'd go in your head, your mask, your eye contact, wear your gown, your gloves, and your gown would be for the session that you were in there. When you came out...
How long might this session be?
3 or 4 hours. Or, yes.
And...
be different in different
well, let me ask you this
places.
then. In non-pandemic times, in 3 or 4 hours, how often would you expect a nurse to change their gown?
I don't know what a HSID unit would do day in, day out in a normal time. I would have to come back to you on that. But I genuinely believe it would be a single use for a single patient.
Right. So if you've got 6 patients in a bay, you might change your gown 6 times. Or is that... I don't want to be overly simplistic about it, Dame Ruth, but is the bottom line that in non-pandemic times you would have changed your gowns more than you did when they were recommending sessional use? All right.
As indeed we would have more staff on a one-to-one ratio in a normal time.
Yeah. So here is you and Dame Donna not supporting the proposal for sessional use or reuse.
And I then also talked to my strategic advisory group, my forthright directors of nursing, and they were equally of the same view, as was the UK IPC cell. And my deputy CNO at the time then fed that back. Donna and my main concern was the safety of our staff, and we just felt that this wouldn't be a safe option.
Well, that was the question, was how do the nurses feel about this guidance? Did you get any feedback from the front line about what they thought about sessional use and reuse?
I can't recall about sessional use versus reuse. I can recall how frontline nurses were in fear of not having gowns and going potentially with just aprons, which is why Donna and I were aligned and agreed so much.
By Easter 2020, this is obviously a major issue for you and your other colleagues. When did you first bring it to the attention of Mr. Hancock as Health Secretary?
Of the supply of gowns.
Or the supply problems of
Supply
PPE?
problems. I can't recall an exact date when I...
Roughly?
I'm sure Mr. Hancock was aware at this time that we were struggling with supply. Of course, my colleague Emily, Dr. Emily Lawson, was supporting the DH, and the DH was leading this, and I'm sure they would have been made aware. I also was on the podium at number 10 with Mr. Hancock. I think it was the 3rd of April, and I think it was the 10th of April, something like that. So he knew then, because we were talking about it. In fact, I talked about it in...
My lady, may I interrupt to help to this extent? We're going to hear from Professor Hopkins, and I think it's clear, unless my memory's failing me, that this change to sessional use and reuse was in fact agreed by Mr. Hancock, so he was aware that there was A, the concern, and B, the change in the guidance in this regard. We'll perhaps deal with that on tomorrow.
I'm not sure if you're the right witness to ask this question, so just say if you're not. As a layperson, I've never quite understood the concept of use-by dates for PPE if it's made of cloth. Now, I can see how, if over decades, cloth might weather, but why does PPE have a use-by date?
As I understand it, the Health and Safety Executive have that as a rule for the protection of staff. So I think it may need to be asked of them.
Yeah, sorry.
Sorry, my lady.
No, not at all. Can I just deal briefly, Dame Ruth, please, with a little later on in the pandemic at paragraph 266, if it helps you. The alpha variant emerged in the end of 2020. And I think we then had Omicron later in due course, and that did not necessarily result in a change in the IPC guidance. But I think you led you commissioned the IPC cell to review the IPC guidance in November 2021. What led you to asking the IPC cell to review the guidance at that stage?
I remember that it was the UK CNOs were meeting, and actually we discussed it as a group, and Sue Tranker, she was my deputy, but then she was a CNO of Wales. She emailed on behalf of the UK IPC, on behalf of the UK Chief Nursing Officers. But yes, we all agreed as a UK.
And what was it? Just that Omicron had emerged by then, and that's why you asked for the review to be undertaken?
Yes, it was. We knew it was more transmissible. That was coming out. So yes, we wanted to do that.
I think
it was also in June 21. From the 1st of June 21, because following a steer from SAGE, SAGE, the most senior scientific advice, they were saying that within the IPC guidance, staff could wear respiratory protective equipment such as FFP3s, masks, following a risk assessment process. So that came on the back of the June as well. June 21.
What was the outcome of the November review that you asked the IPC cell to undertake?
The outcome was a consensus statement that was drafted by the UK IPC cell. Dr. Larry Davis was the chair by then from Wales. So it was a truly multi-UK-wide consensus discussion. And then that went to the senior clinical meeting for a discussion.
I think you say in your statement that the consensus that was presented ended up in a document which supported the existing position on FFP3 use in the guidance, noting there was provision in the guidance for extended use of RPE following a local risk assessment, but agreed to make this position clearer to staff by stating this at the start of the guidance. So, in short, if a risk assessment suggested that FFP3 should be worn, then that ought to be provided to the staff member. Is that right?
And that was in place from June 21.
Yeah. Now, but why is it... I'm sorry to interrupt you. Can I just ask you this on that point? Why is it necessary to move the reference to risk assessments, making it clear at the start of the guidance?
Because feedback was that it wasn't as clear as it needed to be. So the consensus was we needed to make it even clearer to frontline staff that they had the ability to have where risk assessment indicated, they should be able to wear an FFP3.
Was there any concern being relayed back to you that the risk assessments, although recommended in June 2021, were not in fact being undertaken?
I recall colleagues being fed back about whether they'd had a risk assessment recently or moved an area, which is why one of the reasons why it was moved up, but also one of the reasons why we did webinars with chief nurses and medical directors to reinforce the messages to them. And I remember doing webinars with chief nurses and medical directors that said, and we are reinforcing the fact that local risk assessments need to be done, and if by then you need a member of staff needed to have FFP3s, they should have them.
I understand that is what should have happened, and if the risk assessment recommended FFP3, it should be provided. What about the staff member or the nurse or midwife who just wants it for their own peace of mind? In those circumstances, would you have expected them to have been provided with an FFP3 mask?
I know that there were units, there were staff that would do that.
So that was an option still, even if the risk assessment and the guidance didn't necessarily drive you to that conclusion.
Absolutely.
May I turn to a different topic, please, Dame Ruth, and some challenges in particular in relation to maternity care. If it helps you, it's at paragraph 310 in your statement. I think you set out in that paragraph 5 challenges. I just want to ask you about 3 of them. There were challenges with staff absence due to illness and self-isolation. There was obviously the concern about the impact of COVID on pregnant women. The implementation of cohorting, what do you mean by that? What was the challenge there?
So I remember very well that there were units, of course we had women that had COVID, women that we weren't sure had COVID, women that we definitely knew hadn't got COVID. So of course, estates had directors of nursing, chief midwives, the labour ward coordinators were having to make sure they provided safe care and separated care for women to protect the women and the staff.
I think you are aware that Amanda Pritchard, the now CEO of NHS England, has said in her statement that nursing and midwifery staff, due to their age profiles, were forecast to be the worst affected group for absences. Is that right? All right. Against that background, can we have a look, please, at a table in your statement at page 69? So it's INQ. Thank you very much. This table, I think, sets out some of the impacts of staffing pressures on maternity care.
Yes.
And if we just look at the top box to start with, due to the current pressures experienced across urgent and emergency care services, LAS, London Ambulance Services, that are no longer in a position to guarantee an ambulance response to women choosing to have a home birth or birth in one of London's 3 standalone birth centres. And the risk is set out there in no uncertain terms. Should there be an obstetric emergency requiring transfer to hospital, there will be no ambulance response to respond. You set out there that midwives are legally obliged to attend a birth, and LAS, London Ambulance Service, have been asked to discuss this decision with a view to various options. How did it come to pass that if a woman wanted to give birth at home, not go to potentially a ward where she might get infected with COVID and or infect babies and or infect the staff, we ended up in a position where she wasn't allowed to have that choice? Do you know what led to decisions like this?
Yes, I do. So we had over 700 vacancies, 800 vacancies of midwife roles before the pandemic. And you've already heard me say that because of the bursary, we could have had those 700 there. But moving on, that each day, regularly, pre-pandemic and post-pandemic, a midwife in charge of a midwifery service at any of our local hospitals would balance operational pressures with staff absences. But these were of a different scale. Midwifery-led care in a home birth situation is often with 1 and sometimes 2 midwives. So it's particularly resource intensive. Now, whilst women quite rightly wanted to have their birth preference supported, in wave 1 in particular, and I know that my Chief Midwifery Officer, my National Clinical Director for Obstetrics and Gynaecology wrote to me on 23rd of March with this table. At this time, of course, LAS capacity was stretched to the absolute limit because they were transporting patients to hospital with COVID in huge numbers. So it was a difficult situation. And we know that I think it was 57% of birthing units closed during that period. But London closed all of their units.
Well, can we just close that box? I just want to look at one other different type of concern. The third box down, potential withdrawal of epidurals for non-emergency situations are being explored. The choice of epidural for pain relief during labour may not be available, and therefore women's choice of pain relief will be limited. Was there a supply problem with epidural pain relief? Oh, sorry, the use of epidural for pain relief?
Yes. So anaesthetists were a key member of the team supporting patients that were ventilated on critical care. And I believe you heard last week that we didn't, again with workforce plan, we didn't have enough anaesthetists going into the pandemic. There were women that had their epidural delayed.
Maybe not a question for you, but do you know how that was resolved? Did we manage to get more pain relief, or was there an alternative option offered? Can you help with any way that was they tried to manage that?
So the 9th of April guidance did advise that anaesthetists need to be freed up for labour care. Equally, I know that anaesthetists worked extraordinarily hard to provide that care. And there was only a small amount of women that didn't get it. But that, I don't want to trivialise, there was even a small amount of women that didn't get it.
One of the other challenges that you are aware of in relation to maternity care was women not accessing maternity care at all. And I think you say in your statement that there was a NHS Open for Business campaign launched, pregnant women being one of the main target audiences. Did you become aware of the reason or reasons why women did not want to access maternity services during the relevant period?
Well, there was the stay-at-home message that was around, but of course some people still needed to access the NHS, and that included women, of course. We know that there was messages to women, and indeed I gave a message at my second number 10 conference on the 10th of April, that please, particularly aimed at pregnant women, if you need to contact your midwife, please do. And it's important they did. And then, of course, this campaign was launched on the 25th of April.
Can you think of any way in which the messaging could be done differently to try and encourage people to access necessary health services in the event of a future pandemic?
Of course, women were pregnant women were put on the vulnerable list that was developed, and that probably caused even more concern for them. There were lots of women, though, that had very, very good care from their midwifery teams and their obstetric teams. I know the Royal College of Obstetric and Gynaecologists and the Royal College of Midwives really supported professional leaders, as well as my own team, in making sure the cascading the message, which was pregnant women still need to access. Because, of course, it was an area of work that couldn't be stepped down.
No.
It wasn't like elective care. So this needed to continue.
Do you think the stay-at-home message got the balance wrong?
In hindsight, I wish it was stay at home, but not if you're pregnant or you are. In hindsight, yes.
Yeah, right. And I think in particular, during wave one, you became aware of evidence that there was a particular reluctance to access maternity services from Black, Asian and minority ethnic communities. I'm at paragraph 339, Dame Ruth. And did that result in, I think, 4 specific actions being taken to try and encourage women from those communities to come forward? Can we look on screen very briefly at 280429, please? _2. And can you see, this is taken from, I think, the Maternity Transformation Programme, but can you see in the middle there, the England's most senior midwife has recommended the following common sense steps, increasing support of at-risk pregnant women, e.g. making sure clinicians have a lower threshold to review, admit and consider multidisciplinary escalation in women from a BAME background, reaching out and reassuring those women with tailored communications. There's a recommendation about vitamin D, and ensuring that all providers record on maternity information systems the ethnicity of every woman, as well as risk factors such as living in a deprived area, comorbidities, BMI, whether they're age 35 or over, to help identify those most at risk of poor outcomes. So that was the recommendations. But do you know whether there was any positive uptake as a result of those recommendations, or whether any review was done to see how efficacious or otherwise they were?
So the Chief Midwifery Officer, the then Chief Midwifery Officer, wrote those 4 areas out. It was about reinforcing the message. So, for example, vitamin D, a supplement, has been there as an advice for a long time, way before the pandemic. I know that there was a CQC survey done that was done, asked the questions in 2020 and published in 21, that actually showed that white women felt that they had enough information about their pregnancy, 74% of white women, and 81% of women from a Black, Asian minority background felt that they had enough information. So clearly some of that messaging did get across. And of course, local organisations, local trusts, local midwifery teams would be able to tailor some of their communications to their populations. And that was really important. It's the tailored communications that was important too.
Can I ask you about visiting restrictions in the context of maternity care? I think, is this the position, and correct me if I'm wrong, was the guidance that partners should be allowed to accompany a woman in labour?
Yes.
Is that correct?
Yes, it was. So the 16th of March guidance said visitors should be limited to one per patient or less, unless it's a partner in a birthing situation. The same with the 25th of March. And that was just after lockdown, the first national lockdown, which is visitors suspended except for birthing.
Yeah, so generally speaking, no one allowed into the hospital unless one of the exceptions applied. And one of those exceptions was that if you were in labour, you should have your partner with you, or a partner with you. All right. Now, did you draw, or are you aware whether there was drawn any distinction about active or non-active labour?
Yes.
What was the guidance meant to be? Was it meant to draw a distinction, or was that something that was created by those who were in charge of trying to manage visitors?
It was the latter. You know, this must have been really difficult for chief midwives and labour ward coordinators and the like, because they were trying to balance their staff safety and the woman and baby safety. So whilst 97% of women had their partners in labour, half of them only, or half of them, had it during active labour. Now, there is a definition for active labour, but in practical terms, it's when a woman goes from antenatal ward into the labour suite. So that would have been tough for some of those partners not being, and for the women not being there in the antenatal, as well as then in the labour.
So although the guidance didn't make reference to whether a woman was in active or non-active labour, it was interpreted by those on the ground, as it were, to be a potential dividing line as to when partners were or weren't allowed.
I think, yes, I think it's one of those learning points for me for a future pandemic about being more specific earlier.
Do you think partners should have been allowed in for the entirety of labour?
Yes, I do.
Were you aware of reports that some women felt obliged to undergo a vaginal examination to prove they were in active labour and therefore get their partner in with them? Did you hear reports of that?
I heard reports of that, and when I talked to Jill Walton, the Chief Executive of the Royal College of Midwives, some of that could have been true. I find it hard to believe that a midwife would do that. So it could be in translation, I don't know, but in practical terms, it's when a woman moves to labour ward.
Can I just ask you this? When you became aware that there was this distinction being drawn between active and non-active labour, did you or the Chief Midwifery Officer put out any communication to say that's a distinction that shouldn't be being made?
So what I am aware of is that there was some work done by the Royal College of Midwives and the Royal College of Obstetricians over the summer of 2020, which led to the 8th of September guidance, which was much more specific. And a regret I have is that wasn't that specific detail in the 8th of September guidance wasn't in the original guidance.
I think in your statement you say that by the first week of April 2020 you'd had reports coming to you and indeed to the Chief Midwifery Officer of not only partners not being able to attend the full range of appointments, scans, partners not being able to stay with their mother and the baby immediately after birth, a range of difficulties in relation to people accompanying pregnant women. I think you say in your statement that decisions about which scans were able to be attended with, how long the partner could stay after the birth, were decisions for trust to make. Is that right?
Yes.
Do you think that led potentially to an inconsistency of approach, with Trust A doing one thing and allowing a partner in, and Trust B doing something different and not?
Well, of course, their estate is different in different organisations. So what may be safe for staff and for women in one unit may not be the same in others. And some of our estate in maternity units is extraordinary and has great facilities that will allow for this much easier. Some of our NHS estate in maternity services, for example, in sonographers for ultrasound rooms, is very tight, very small. And that created a difficulty in practical terms for those leaders and staff.
If there had been more PPE available early on in the pandemic, which the visitor, the birthing partner, could have worn, do you think that might have affected the stance taken on visiting restrictions?
I don't know. I wasn't involved in the visiting restrictions consideration. That was the clinical cell reporting into the EPRR structure. So I can't tell you whether PB supply was part of the decision making. I can tell you, though, that midwives were nervous, as were nurses, we were nervous. And Royal College of Nursing and Royal College of Midwives, quite rightly, were equally advocating for the support of their staff to be considered.
If there had been more testing available earlier to show that the partner was COVID negative, do you think that might have affected the way the visiting guidance was drafted and published?
Oh, without doubt. Without doubt. So it wasn't until the 14th of December guidance that, you know, one of those key actions was around, we had LFD, we had the lateral flow tests. If we'd had lateral flow tests at the beginning, with us being able to say whether a partner was positive or not, gosh, that would have relieved a lot of anxiety and tension between staff and women and families and provided better outcomes or experience.
Can I ask you briefly about postnatal support? Do you consider that to be an essential part of maternity care that should be prioritised in the event of a pandemic?
Absolutely. Antenatal care, with the scans, postnatal care, I agree completely.
Did you become aware that health visitors were being redeployed and so were not able to visit new parents?
I was made aware of that, and Alison Morton from the IHV very helpfully made me aware, as well as, of course, the Chief Nurse for Public Health. That I didn't have responsibility for health visitors and school nurses until November 2023. But yes,
The IHV is the Institute of Health Visiting,
yes,
is that
it
right?
is.
Can I ask you about face-to-face support for new parents? Clearly some meetings had to be done virtually, but do you think that there should be more prioritisation of face-to-face support for those new mums and dads?
I think it was the IHV very helpfully set out concerns about how we should not redeploy health visitors away from their core duties. Future pandemic health visitors should stay being health visitors. They should not be redeployed. And then they would have more ability to do the face-to-face contact.
Can I widen the topic of visiting to more general restrictions on visitors? Clearly you were working on the front line at times. What was the impact on patients and indeed staff of not having a visitor when you broke an arm, had an appendix out, whatever the position may be? What was it like for them?
Awful. It was particularly with end-of-life care. And whilst the visiting restrictions were done to reduce the footfall, to reduce transmission and to support the balances of staff safety, I can understand if I had a loved one in hospital at that time, like I did actually.
Different topic, please.
Just before you move on,
I'm sorry.
And what about those who needed extra support? So, for example, I think we heard about people who are disabled, or I think we heard from a gentleman whose daughter was Down syndrome. And what about people who needed the extra support? Must have been dreadful for them. Even worse.
Yes, although I do believe the guidance was there that people with a learning disability, to have somebody to support them, would have been there. And in practical terms, the vast majority of times that would have happened. But these were scary times for staff and for patients and for carers. If we'd had testing at the time, we could have tested more easily and allowed more people in. Difficult decisions, my lady.
Another difficult area, if I may, and DNACPRs, do not attempt cardiopulmonary resuscitation. Did you become aware of any instances of the inappropriate use of DNACPRs?
Could you direct me to my...
Yes, I think you deal with it at
I've got it.
paragraph 364,
I've
Dame
got it.
Ruth.
Sorry, I apologise. Yes, I did become aware early in 2020. It was raised with me directly, actually, at number 10. I think it was my first number 10 experience on the 3rd of April. And DNACPR is a very sensitive area, very important area, an area that is part of end of life care planning. It should be done sensitively, it should be done with the patient and with family if possible. I've been part as a nurse in the past, being part of those conversations. But to blanket DNACPRs was wrong.
Yeah. You, I think, in your statement say that in April 2020, you co-signed a letter along with NHS England's National Medical Director to reiterate that blanket DNACPRs should not be used. And I think you said that the issue was raised again with you by the Queen's Nursing Institute in September 2020. And I suppose really the question is if you told everyone in April 2020 to not do it, can you help as to why in September 2020 you're still hearing reports of blanket or inappropriate use of DNACPRs?
So I'm really grateful that Q&I raised this directly with me. As I understand it, the survey was done in May and June 2020, so still after the guidance, the letter had been written. It was raised, I think she said, Crystal was the 16 out of the 163, so it's still there. When I went back to the Q&I, because of the way the survey was done, I wasn't able to find out which of the care homes it was there. But there was a difficulty still in getting the information out.
So, putting the location, I should say, to one side, there still seems to be an issue, notwithstanding the efforts you made in the April 2020 letter. And in March 2021, is this right? You were among senior clinicians who signed another letter reiterating the NHS England position that it was unacceptable for people to have a DNACPR on their record just because they had a learning disability, autism, or both. What prompted that letter in March 2021?
Because there were still further reports coming through. But between all of these, the National Clinical Director for end-of-life care, working in the medical division, was working and taking all of this into the work on advanced care planning. This is something that should not happen.
Also, I've heard on my travels, it wasn't just that there are a number of aspects to their use. The blanket use you talked about with people with a disability without consultation of the patient or their family, but also it wasn't just used as I've been told. I've yet to hear much evidence on it. It wasn't just used for do not resuscitate. It was used for do not treat. That's totally wrong, isn't it?
It is completely wrong. It's a fundamental principle of the NHS, and one that I hold dear as a nurse, or a former nurse now, to care for and treat people on an equal basis. So I fundamentally disagree with blanket DNAR and the same with treatment, my lady.
Can you help as to why you think people merged a DNACPR notice, which is very specific, with escalation of care and end-of-life care decisions? Do you know why they got the two confused or elided them?
Good or best practice excellence in advanced care planning for end of life does include a conversation about DNACPR. If I was in a situation that I was facing a terminal illness, I'd want to have the conversation, and I'd expect people to have the conversation with me. But I wouldn't want it as a blanket decision.
Different topic, if I may, and I have to just deal with a number of discrete issues now, so forgive me if I'm jumping around. Earlier this morning, you made reference to risk assessments for Black and Asian and minority ethnic workers, and it's at paragraph 192 in your statement. And I think you mentioned that you were responsible for increasing the pace of implementation. I just want to go over that so we're clear that what the problem was and what you did to try and solve it. Just help us, please. I think you were aware of the disproportionate impact of COVID on Black, Asian and minority ethnic staff. And I think there was concerns, there was work being done, I should say, around risk assessments for that particular group of people. What work was being done, firstly? Was it just risk assessments?
So this was a piece of work led by the Chief People Officer team. But as, of course, a professional and fellow executive, I inputted into it, and I had an opinion. Because, of course, the BME's Strategic Advisory Group had raised it with me, and I was in regular contact with them. The risk assessment was key. The risk assessment is a conversation about a person's risk to working in a frontline COVID environment. And without the risk assessment, action couldn't get taken, which is why I was very keen, probably forthright, in wanting it to be brought forward so it was achieved sooner. Because without the assessment, the action would be delayed.
So was it in short that the plan for implementing the risk assessment was going to be within 4 weeks, and as a result of your efforts, that came down to 2 weeks to roll this out? Is that where we get to?
Yes, I proposed that it would be 2 weeks. I cannot recall whether the 2 weeks was achieved or not.
Right.
I'm sorry.
Do you know why it was that a 4-week period had originally been suggested?
Because it's a huge task. And I'm not criticising my colleagues at all, because it's a huge task. It's one that we would be requiring a lot of energy and effort of trust leaders.
Do I take it, though, that you felt that the 4-week period was too long?
Yeah, I wanted it sooner because without the assessment, the action couldn't take.
Do you know whether the effects of those risk assessments were monitored and reviewed to make sure that it was happening and it was helping BAME nurses and midwives?
This wasn't just for nurses and midwives, of course. Yes, the CPO team would have been monitoring this, the implementation and the impact. I also know from my own feedback, though, that people were being assessed.
different topic. It's my fault. I touched on the issue of long COVID earlier this morning, but I didn't, in fact, ask you when it was you as CNO became aware of the effect of long COVID on healthcare workers. Now, I don't mean a precise date, but can you pick a point in the pandemic where it came to your attention?
I'd have to go back to my notes to give you a more accurate picture, but I'm very grateful to Dr. Elaine Maxwell, who brought forward the concerns around long COVID. I'm so sorry, I can't recall when that was. I don't want to give you a false date.
Just before we conclude, please, Dame Ruth, can I ask you some questions really about the health and well-being of the nurses and midwives that you led? And can I ask you, please, to turn to paragraph 182 in your witness statement? I think you speak there in particular of surveys conducted on critical care staff, and that work was being led by Professor Kevin Fong, and the output of those surveys was shared with you. And could we show on screen, please, 421181. It's behind your tab 10 if you want to look at it, but it might just be easier to use the screen. And was this the note that he provided to you?
Yes, it was. It's a note that was dated the 10th, as I recall, but I received it on the 30th of July, 2020.
Right. And we can see there just the summary for these purposes. It notes, assesses the impact of wellbeing and psychological health on the frontline ICU and anaesthetic workforce. There was a pilot survey across 5 hospitals, more than 700 respondents. And there is evidence of significant psychological harm to frontline NHS staff following the first COVID surge, with high rates of post-traumatic stress amongst frontline professionals. When you received Professor Fong's summary here, what steps, if any, did you take to try and establish, A, whether it was right, and B, try and ameliorate the harm that was caused?
So I was raising back in May 2020, before I received Kevin's report, the need for something of a wellbeing service specific for nurses. Obviously, the wellbeing work was very good and developed very quickly and was accessed widely, but I was wanting something more for nurses. So I started asking my head of nursing to develop the professional nurse advocate programme. But when I had Kevin's briefing, I met with Kevin virtually, but I met with Kevin several times. As more data came out, I met with Kevin. I believed his data, I took his data, and I wanted to make sure that we did everything possible.
Pause there, because I'm going to ask you about the programme in a moment. But is this the position that at the end of July 2020, I think you attended a psychological harm roundtable and reported to people at that roundtable that 4 staff nurses had died by suicide, with 1 further nurse in ICU and a member of staff who'd made an attempt to take their life?
Yes.
Now, against Professor Fong's work, the reports you made at that roundtable, tell us, please, about the professional nurse advocate programme. What was it meant to do? What did it actually achieve?
So the Professional Nurse Advocate Programme was a programme of restorative clinical supervision. It came about by my experience, what I was hearing, and my head of mental health nursing, mental health nurse by background, saying, we're going to need to provide some more support for particularly critical care nurses. So we developed a programme, and it was a programme that supported nurses in their workplace.
Give us an example. What did it actually do?
Have a conversation, check in with people, make sure they're okay, debrief. It was there as a support. It was very successful. The feedback from it was very successful. And of course, then we needed to roll it out. And I think that's what my comments were on that round table. It wasn't just for critical care nurses we needed to do this. It was for those that needed to go into critical care. And of course, what we realised was there were lots of nurses elsewhere that wanted this. And so it's been more rolled out. I put in more money into it from my budget. And we developed this, you know, Kevin was involved with the development of this and saw it in reality. But it wasn't the only thing we did, of course. We ended up having practitioner health as well opened up for nurses, which was really important.
Can I ask about you, please? Is it right that as part of your role as Chief Nursing Officer, you were the victim of abuse meted out to you online?
Yes.
Can you just give us a couple of examples of the kind of things that were said to you? Or summarise it in whatever way you can, Dame Ruth.
Yes. The one thing I have learned throughout the whole of this is the importance of acting with integrity. And sometimes that comes at a cost. And sometimes you have to make decisions or be involved in decisions that mean that, in social media in particular, you are vilified. Or by some other senior people, you're vilified. I wasn't the only one. But it was pretty horrible.
The future, if I may. If you were to try and summarise what worked well for the nursing and midwifery profession, what would you say?
The workforce expansion worked well. The students that came, all 23,000 of them in wave one to support us. The international educated nurses that throughout the pandemic, joining the temporary register, joining the substantive register, worked well. Delivering the 50,000 extra nurses early and overachieving worked well. Very well.
What did not go well from the nursing and midwife perspective?
A number of areas. So we went into the pandemic with vacancies, nearly 40,000 vacancies. We could have had 5,000 less.
Yeah.
The maternity visiting guidance, I genuinely believe could have been more specific earlier. And that would have been better for women, better for their partners, and better for the staff. And if we'd only had testing in the early days. If I think about the nosocomial transmissions, if only we had testing, because we didn't have testing even for day 3 testing until 20th November. So it wasn't just we didn't have testing to begin with. We didn't have testing for a main part, a big part of the early pandemic.
If you could make a recommendation or two to her ladyship to consider, what would be your top picks, if I may put it colloquially?
Ensure we have the workforce supply and everything we can do to either bring back the full educational package or write off of debt. But the domestic supply of future nurses and midwives in this country is key to a future pandemic. And second, my lady, it would be that we're able to have testing. Because not only would visitors have been back earlier, staff would have been safer, but patients would have been safer too.
My lady, they're all my questions. There may be a number that you wish to
There was just one other one I wanted to ask. You mentioned just then about things that didn't go well, and you talked about visiting guidance with maternity care. Presumably, you would add to that visiting guidance when it came to people who required carers. You remember I asked you about people who had difficulties and relied on a family member for support. If that guidance that you say should have been followed wasn't being followed, presumably you'd say that too is something that ought to be.
Yes. I said the maternity because that was extremely difficult for lots of women, but it included people with a disability of whatever disability too. I agree with you.
Thank you very much indeed, Dame Ruth. I can't believe that people could be so stupid and wicked as to subject you to the kind of personal abuse that they did. Just ignore them. I'm afraid it looks like it's a fact of life, and it is a dreadful fact of life. So I'm sure we're all genuinely sorry that that happened to you. I know it can't have been easy giving evidence today, reliving not only your own experience, but the experience of your colleagues. So thank you very much indeed for your help.
Thank you.
Right, I'm asked to break now for lunch and come back at 20 to 2.
Thank you, my lady.
All rise.
meet the needs of their patients. The critical care network across Wales, the trauma and critical care network, support them and helped have mutual arrangements. So I'm happy to say we never ran out of a critical care bed in Wales. Anybody who needed level 3 care got level 3 care. There was never a moment when there wasn't a bed available. But it may not necessarily be the local bed available. It might be in the next hospital, in the next health board area. And the network helped make the movements around because they knew what vacancies there were. So it was much a collaborative approach across the whole system rather than individual hospitals trying to cope.
So there may have been the bed available and staff available, albeit at a diluted ratio. I wanted to ask you, though, do you think that that dilution impacted the level of care that patients got in Wales?
I would say it added to the stress on the staff, all of the staff, because it wasn't just the nurses, obviously. We had more patients, therefore the medical staff and so on were also impacted. Like other parts of the UK, we developed supplementary teams that would support them. So we'd have turning teams, for example, that had
literally
turn patients for this an approach called proning. It was found that those were very ill. If they did well, if they were also put face down, and that takes about 6 people to do that. So we recognised that the critical care nurses would be under tremendous pressure. So we tried to bring in things that would support that. But to be honest, I suppose if you're looking after twice the number of patients, it's going to be difficult.
Yeah. I follow bringing in someone who can physically help turn the patient or prone them. What about actual support for them, though, dealing with the stresses now of dealing either with 2 critical patients or 3 critical patients day in, day out? Did you as CNO do anything to try and help them in a sort of more pastoral context?
So I met with the executive nurse directors from about the middle of March onwards. I think it's from about the 18th of March onwards, twice a week. And throughout the first wave, certainly the welfare of staff and the concerns about critical care staff and the pressures they were under were part of our conversation. Obviously, the health boards have responsibility for the welfare of the staff as their employer. They have a duty of care. What we did was we supplemented that local support that was being offered by a national offer as well of resources. And that was facilitated by Health, Education Improvement Wales. Remember I said there was a body that helped with the workforce. And so we have had contracts to do with Samaritans. We extended a programme called Health for Health Professionals, which is an approach that was pre-existed pandemic, which was for doctors only, but we extended it for all staff and students during the pandemic, which is where if you rang up and said, I'm in need, I'm in distress, you would be assessed by a doctor and then a programme would be worked out for you. Some of it would be one-to-one guidance and so on. And then we had lots of programmes like Silver Cloud, which was online mental health stuff. It wasn't specifically for critical care. There was a doctor...
Can I pause you there? Because I want to
course.
just look at one very specific issue in Wales. And I'm sorry to have interrupted you, Professor, but
fine.
can I ask, please, that you look behind tab 9 and we call up on screen 412539 and actually start at the back of that document on page 0005. Because clearly there was pressures at the beginning of the pandemic, but I want to ask you about an email chain that is from January 2021. And to put it in context, Andrew Goodall, who was, I think was the chief executive at the time of the Health and Social Services Group.
Yes, that's right.
He sent round to a number of people a newspaper article talking about the dilution in England, which then prompted a discussion about the position in Wales, just for the context. And if we go to page 3, having skimmed through the article, I think he was asking you what was going on in Wales, and you say at the bottom, is there anything I should be saying back to Andrew, re-dilution of staff in our units? Can you give me a summary position? and then up to the email above. So here we are, 12th of January 2021. And you are addressed, sorry for the delay in replying on Monday, for example. 11 of the 13 IC units were on a stretched nursing ratios, 1:2 for level 3 patients. Redeployed staff have been moved to critical care to help out these units. However, given the hospital strain and vast number of patients in critical care, redeployment hasn't actually been 100% enough for all critical care patients units in Wales. Uncertainty around the impact of this on the quality of care and ultimately on the outcomes. I've raised staffing ratios in the critical care network meeting. They were of the opinion, particularly as in many units, there are not redeployed staff to support stretched 1:2 care. We should only further stretch this by exception.
Yes.
So by January 2021, is it fair to say that the stretch might be an understatement for the 11 of the 13 IC units across the nation?
Yes, it was very tough. During the second wave, to a degree, I suppose it was worse than the first wave because a lot of staff were needed because we were starting to reopen other bits of the hospital. So there weren't the availability of staff to redeploy. I think the network was very sensible in saying, look, we can't have sort of 1 to 3. That would be too dangerous because there aren't the supplementary staff to support them. So that's what this was all about. Because at that time we were having other guidance to say, you might still be able to do 1 to 3, but no further than that. I think that's what the UK guidance was kind of suggesting. And the network, as I said, with our sounding board about what was actually happening on the ground, was saying that wouldn't be safe to do that. And so we listened to that.
Slightly different topic, but still on ratios. I think in your statement at paragraph 257, there was a concern raised with you about ratios of registered nurses to patients in the field hospitals in Wales. Can you help? What were the ratios in the field hospitals and what was the concern?
So it wasn't necessarily that I was worried about the number of nurses. It was more how the makeup of the teams were being constructed. So field hospitals in Wales were not intensive care provision. They were actually step-down provision. So we wanted to increase the flow of patients out of hospital. So these were people that were taking some time to recover before returning home or needed to have some more support before returning to a care home, for example. So I discussed with the nurse directors, and this is what this document starts to talk about here, is how are we going to do this? What kinds of teams should we have? And the nurse directors were of an opinion, actually we should have occupational health nurses, mental health nurses, physiotherapists, rather than it all be nurses, registered nurses and nursing staff. We needed to have a more multidisciplinary team. And so the nurse directors themselves shared their practice, and as the field hospitals started to come live, if you like, in a sort of a phased approach across Wales, they learned from earlier experience to work out what would be best.
Different topic, please.
Okay.
The Nosocomial transmission group.
Okay.
And it starts in your statement at paragraph 316, but it was established, I think, on the 19th of May 2020. You jointly chaired it with a Deputy Chief Medical Officer in Wales. What was the purpose of the group, please?
So it had a number of functions. We were there as an advisory and oversight group to look at the evidence-based guidance that the system needed about giving advice on everything from how far apart hospital beds should be to handling how the deceased person's body should be managed. It was there to look at the education and skill set around IPC and try to support how the system was responding to hospital-acquired infection, which is what nosocomial transmission is about. Later on, after a few months, we took on a particular role in oversight of outbreaks because we were finding that the health boards, some of them were struggling to get on top of outbreaks of the infection. And so what we wanted to do is promote best practice and keep a closer eye on the system to help them deal with that. So we took on more of a role to do with outbreaks later on.
I think in your statement you give a number of examples of operational matters that the group became involved in. But I would like to ask you about one, please.
Sure.
If you look in your statement at page 121, it's in relation to the wearing of face masks in non-clinical settings. And can we just, we haven't heard very much about non-clinical settings yet, but what are they in a nutshell?
So if you like, it's the backroom arrangement. So that'll be your folk in offices, perhaps dealing with ordering kit. It could be anything where you're not actually looking after a patient, I suppose would be the simplest way of doing it.
Okay. Now, I think the position is that there was UK IPC guidance issued in due course by England, and I think it may have been Scotland as well.
That's right.
That said that face masks or face coverings should be worn in both clinical and non-clinical areas. And when that came out in England and Scotland, in Wales decided not to make face masks mandatory in non-clinical settings. Have I got that right?
That's right.
All right. Now, why did Wales take the decision not to make face masks mandatory?
I was not the policy lead on this. I did take sort of the steer from the CMO who had given advice to government on this issue. So we had found that the evidence around face coverings and face masks in a sort of a community setting rather than a clinical, I'm not talking about the kind of delivery of care settings, was less robust than it was for clinical settings. And particularly concern had been expressed in the summertime about how people in the public were actually using face masks. It increased things like touching your face and not, it caused people to perhaps not follow some of the other guidance. It took more risky behaviours and so on and so forth. There's a long list that I've listed out in my statement. So the CMO was of the view that the evidence wasn't strong enough to require that. So we had taken the policy position in Wales that we'll do it where the evidence took us, which is in clinical areas. Now, I think in his evidence, he's gone on to say how that then...
Well, we'll hear from Mr. Atherton in due course. But can I just ask you this? Do you think, though, that by not making face masks mandatory in those areas, there was a lack of protection for those workers who were in the non-clinical areas?
I think hindsight's important here, because at the time we felt that if you kept distance and had good ventilation and had other sort of environmental factors in play, the risk was probably low. That's what the evidence was telling us at the time.
Pausing you there, Professor, is a non-clinical area likely to be well ventilated in most of the Welsh hospital estate?
Some of it, probably not so much. I couldn't hand on heart say everybody was able to open a window and so on and so forth. Some of our estate is very old in Wales.
Do you not think that the benefit of mask wearing outweighed the asserted downsides of people touching their mouths or touching the mask?
At the time, we didn't feel it did. I think as time went on, and I'm looking in hindsight now, not from what I felt at that moment, understanding about how the disease was spread, would probably give different advice now if we were to go back in time. But at that moment in time, the evidence wasn't very strong about wearing face coverings unless you're in a high-risk area, which is direct patient care, enclosed, confined areas, in well-ventilated areas with other good IPC practices, the risk was less.
I'm so sorry, I didn't interrupt. In due course, though, did Wales make a face mask wearing mandatory in non-clinical areas?
They did.
Was it about 3 months or so after?
Yes, it was the autumn. I can't remember exactly the date.
And why did it change its stance come the autumn?
I think partly it was leading to confusion with the public because there were different messaging across the 4 parts of the UK. Our intelligence was growing about what was needed to prevent infection. I think that was it. But as I say, I wasn't the policy lead for this. I was in more of a supportive role. The chief medical officer was, if you like, the lead advisor on this. I don't have personal expertise in infection prevention and control measures. I'm not a scientist by background. So I needed to follow the advice I was being given rather than saying, no, I think I'll go UDI here and make my own advice.
I think in due course, certainly there's been some studies to suggest that infection rates went down when there was universal mask wearing. Although it won't be a decision taken by you in due course, do you think that had there been universal mask wearing throughout the hospital estate, that would have helped prevent infections of patients and indeed healthcare workers?
I'm sure it would have helped, but also the other practices were very important. Face mask wearing on its own would not stop the spread of disease. If people were not hand washing, were not keeping distance, and doing all the other things that we were advising. So I would say it's part of a package. It's not a panacea of stopping all infections, but it certainly has a part to play.
One of the other things that the Nosocomial transmission group did was set up what's called a sort of lessons learnt group. I think it was was it the early learning platform?
Yes, we called it CORSIL, which sounds like some sort of chemical you'd use, but it was the COVID early learning is what it was. It was a platform.
And what was what were the kind of things that were being reported via the early learning platform?
So this was set up so that anybody in any of the health boards across Wales and the trusts as well could say, look, I've done this thing, whatever it was, large or small, and it either worked or didn't work, and perhaps you shouldn't do it. So it could be anything from cohorting patients who have the disease when you've got lots of open plan areas to anything. It could have been anything at all. Throughout the pandemic, that was available to people to do that.
Do you think it was a useful reporting platform?
I think it was helpful. It had one particular limitation in that it was on a separate IT system to, we have lots of different IT systems, my lady, across the
I've got
service.
that T-shirt.
Yeah, you know exactly what I mean. So it meant that rather than it automatically sucking things and easily transferring information, you had to go out of your system into another system and then report it. And I think it put off a few people. So I think it was useful. I certainly would have it again, but probably on a system that is a little bit more joined up.
I just want to understand the genesis of a document I'm going to ask to be called up on screen, which is 473936, and we can go to 0001. I want to understand how this document was reported. It's a COVID outbreak reporting. Is this linked in any way to the early learning?
No.
No. That was my error then, thank you. Then can we nonetheless look at this document though, please? This is an example, is it not, of weekly reports that were submitted showing outbreaks and changes and the location of the outbreaks within Wales. Is that right?
That's right.
And here's one for the 11th of December 2020. Who is collating this information?
So a little bit of context,
Yes,
if that
please.
would be all right. So outbreak management was previously managed by Public Health Wales pre-pandemic. But we were finding that the data had a delay in it. So you'd have a report of the outbreak that was last month. Well, when you're managing outbreaks, you needed it to know every day. So the Nosocomial Transmission Group developed a form that was required to be filled in by the operational manager in each hospital on a daily basis and sent in to the Public Health Wales and Welsh Government mailbox. And so this report is the data that was submitted by each of the health boards about what was happening. So that's the number of patients involved in any outbreak, the number of staff affected, and any patients that had died within 28 days of the outbreak. So it's showing us a direct impact on the patients of those outbreaks. So we needed to know exactly where they were happening, how quickly they were coming under control, and what the health boards were, actions they were taking. So they were also telling us what they were doing.
Just pause there and we'll let's look at one example. Can we turn to page 5 in this document, please? And I think a submission, forgive my pronunciation, by the Health
Yeah.
Board.
Yeah.
Thank you. But if we see what that health board submitted that day, and I presume all of those there are different hospitals
Yes.
with the names of them, and you can see across the 4 sites there were 2 wards closed in Llanwilly. The position there in Prince Philip Hospital, they've had to transfer patients.
Yes.
We've got a ward closed in Withybush and a slightly different position in the community hospital. And was this being done on a daily basis?
So the data was being reported to us on a daily basis, and we had sort of a weekly position, if you like, to see what was going on. But it was useful for both us as the government and Public Health Wales to look at what's happening across the whole system, but it was also useful to the managers in the hospital because they have the data was shared back to them, if you like. They could see what was happening. It also meant that if, say, Hywel Dda was struggling in Prince Philip Hospital, yet down the road another hospital was doing really well and very quickly getting under control, we were able to say to them, you need to talk to that manager to see what they're doing that you're not doing to learn from this. So this was a really transparent way for us to see what was going on, and a really good way to help the system learn, because people were obviously catching the disease in hospital when they were already ill and there because of another reason.
Well, I wanted to ask you about that, actually, because I think it's right that there was guidance issued that said that there should be testing for all patients admitted into hospitals in Wales, issued on the 3rd of June of 2020. And I'm in paragraph 324, if it helps you, Professor.
Yep.
So the guidance came in on the 3rd of June for testing of all patients, but was brought in Wales on the 15th of July. And can I ask you, why was there a gap between the guidance being issued at the beginning of June and then not coming in until 6 weeks later?
I think we gave them a run-in time to actually get the systems in place in order to do that consistently. Now, obviously, once the guidance is out there, there'll be early adopters, but some folk will take a little bit longer to get systems in place. So often we would give them a couple of weeks time lag to get to a position where everybody was doing it. It's a big system.
We heard this morning from Dame Ruth that she thought that the rollout of testing would have a big impact on the healthcare system's response, and indeed in particular on nurses and midwives, and visiting restrictions,
Yes.
for example. Do you agree with her as the importance of testing in the event of a pandemic?
Absolutely. If you want to try to enable a system to keep delivering other care, you need to separate out those folk who have got an infectious disease from those folk who don't, so that you're able to have, I hate to say sort of a clean system, but those are not affected. I don't know what language I should use here, which doesn't sound inappropriate, but you understand what I'm trying to say. If you want to run an orthopaedic service, you want to know those folk that have got it and who haven't got it. Because the last thing you want to do is bring somebody into the system that's then going to contaminate the system that they've gone into. So testing was very important, which is why it was a requirement.
Yeah, and am I right in thinking that testing of healthcare workers in Wales was not fully rolled out until March 2021? Is that right?
I believe so. I can't remember exactly the dates.
Do you think it should have been rolled out sooner for healthcare workers?
I think that the issue was more around asymptomatic testing and symptomatic testing. So we did have testing availability, and staff could test if they had any symptoms. So there was a lot of issue about when they should return, because obviously it's shortened the number of staff you had if they were off sick for a long period of time. So you needed to know when they were fit and safe to return to work. I think the issue is more around asymptomatic testing, because at the early days we didn't know that the disease could be spread by those who weren't showing any symptoms, and therefore you didn't know that they had it in order to spread it. Testing was not my policy area, so I may not be the best person to fully explain all of this.
But on that point, sorry to interrupt you.
No, sure.
I think I heard that asymptomatic transmission was recognised by the summer of 2020, certainly by the autumn. Mm-hmm. So it still leaves quite a long gap until Wales introduced testing for all healthcare workers, symptomatic and asymptomatic.
Yes, I think that's about right.
Is it a capacity issue?
As I say, I'm not really the best person to ask about this, because I wasn't involved at all in anything to do with the testing. I'm sorry.
No, all right, don't worry. We'll seek to answer it through someone else. Okay. IPC guidance, please. Can we be clear at the outset? What is your role in relation to the approval or otherwise of IPC guidance?
The IPC guidance, we had an agreement to work collaboratively across the UK, and there was a UK IPC cell. Public Health Wales contained our experts, and so we sent our representatives of experts to the UK cell. Once the cell had made advice, it then was brought back to Wales and was presented to the Nosocomial transmission group, because that seemed a sensible place for it to go. But it did feature in other conversation, but it was mostly at that.
Right, so you saw it as part of your role on the NTG?
That's right.
I'm sorry to interrupt you, but did you then comment on the guidance?
So the NTG looked at the guidance and looked to see whether or not there were things in it that didn't fit or might be challenging for us, or a sense check, I suppose it would be. The people who were sent from Public Health Wales also sat on the NTG, so we were able to sort of say to them, so does this sound about right? Were you able to say the Welsh position in the development? So it wasn't like there was a great separation out. We were all one and the same, if you like. So the UK guidance was given to us as a best practice guidance. The NTG then received it to work out what was best for the system. But I understand the UK cell were drawing scientific evidence from things like SAGE and nerve tag, which we weren't involved with at all. Right.
So in your statement where you say the CNO played no role in providing advice or guidance as to the types of PPE or RPE that nursing or midwifery staff should use in the workplace, that is correct in terms of your CNO role, but you had a role reviewing it as part of your role chairing the NTG. Is that a fair way of summarising it? And can you recall now any examples of you in your NTG capacity saying to the cell, we don't agree with that recommendation, or that bit of guidance we'd like to reword or amend?
No, I do recall us talking about face coverings in non-clinical areas, which we referred to earlier. But on the whole, because we'd had experts from Wales help design it, it mostly fitted our system. So there was very little, oh no, we don't agree with that kind of conversation.
I think you were made aware, though, in your CNO role of issues in relation to FFP3 masks. And if it helps you, Professor, it's at paragraph 309 in your statement. You say that there was issues regarding the fit and suitability of PPE raised with you during meetings of the nurse directors. And you give an example there that on the 3rd of April, concerns were raised around FFP3 face masks used in critical care that were not fully waterproof, and staff were resorting to double masking. I assume that means wearing 2 FRSMs, does it? Mm-hmm. And how were those concerns? So they were coming to you from nurse directors, what presumably from the front line to the nurse director and director to you?
That's right. So we had a PPE cell which pulled together folk from procurement who knew about the supply chains and what we had in stock, along with folk from service, which is about distribution and so on.
Right.
So my role here was really to make sure any issues I came aware of were reported to the cell for them to take action on. And that's what I did. Whenever there was an issue raised about any PPE, whatever it was, or shortages or difficulties in accessing it, I made sure it was reported. We had a lot of stock. Often the issue was around distribution. So people on the front line were not necessarily receiving what they wanted. We didn't run out of stock. It's just not necessarily, we had everything, but not necessarily in the right place.
Right. Let me ask you about that specific example there, though. There was a concern about the masks in critical care not being fully waterproof. What did you actually do when a concern like that, who did you tell? How was it resolved?
So I think in the text here, I mentioned I talked to David Goulding, who was our health emergency planning officer, because he was part of the cell. But in other examples, I would have gone to Dr. Chris Jones, who was the Deputy Chief CMO, who was chairing that cell. If it was, depending on what it was that was the issue, I would report it to a lead policy officer in that cell. If I felt it was a distribution thing that might be inside a hospital, because I think I gave an example further on in my statement about that, I would make sure I also told the nurse director, I've heard from your staff there's an issue. I think you should look to see if that ward or that team are actually getting access to the things that they actually need. So sometimes it will be back down the chain rather than into policy. So I was more of a conduit of information than a fixer of the problem.
Right. And I think you set out in your statement a number of other problems, for example, straps perishing.
Yes.
You also dealt with an example on the 19th of May where you, in one of the nurse directors noted that up to 50% of FFP3 masks were failing fit testing. I just wanted to be clear about that. Did you mean that the fit, it didn't work 50% of the time?
Yes. It was a lot of it was not suitable for the staff there, so they couldn't fit them tightly to the face, so that you could have a good seal. So I would say, if we come on to recommendations, we need to think about having masks that fit different shapes of face. Different ethnic groups have different shapes of face. If you have a beard, it's very difficult to have a good fit. So there's lots of things around fit that probably need to be looked at in the type of stock we have.
Were you made aware of any specific issues regarding PPE fit for ethnic minority nursing staff in Wales?
That's what I was referring to there. Some of that was to do with that. If you have different shaped face, it is a little more difficult.
You mentioned to my lady that in due course there might need to be a recommendation about broadening the types of masks that might fit different type faces, but if you're made aware of a problem with PPE fit for ethnic minority staff in Wales, what steps did you take to try and address that, given you can't just rustle up a new mask overnight?
No, again, I fed it into the PPE cell because they are the ones that were working with our NHS shared services. What we have in Wales is an arrangement where all the health boards fund one body to do things like procurement for them. It's a way of saving money and being more efficient. So if they became aware that they needed to have different kinds of equipment, that would be the place where the procurement would be dealt with. So that was the route back, and they sat on the PPE cell.
Now I turn to visiting restrictions.
Okay.
We have heard that visiting was restricted unless there were a number of specific exceptions
Yes.
that applied, for example, end of life or a woman in labour. Can I ask you this? Did you have any role in developing the restriction on visiting guidance?
Yes. It was I was the lead advisor on that.
In developing that guidance or determining that you shouldn't visit unless you're in one of the exceptions, did you consult with any people like disabled groups or any of the groups that might be impacted by that decision before coming to your ultimate view?
So there were 5 versions of guidance. So if I take us at the very, very beginning, when the complete lockdown came, the nurse directors asked me to set out a policy position for Wales because they felt they needed to have one voice for Wales, and the Welsh Government was able to do that for them. And I agreed with them what it is that they thought was suitable for the NHS. And so the very first iteration, which was in the beginning of middle of March, 20th of March, I think it was very restrictive. Over the iterations that followed that, it became far more nuanced and far more permissive as we heard more voices saying about the impact and certainly issues around folk that may have dementia or other cognitive learning, about the importance of people who might need an interpreter. So there were lots of folk that might need to accompany a patient in any part of their hospital journey would need to be involved. So yes, we listened, but in the very first, I was responding from a request from the nurse directors in Wales to say, please, Jean, will you just give us a statement about what we should do to lock down? There was a tremendous amount of fear at that time caused by it. And visiting, they were fearful for the staff, for bringing it in. I have to say, visiting and the role I played in visiting is a thing that has stayed with me the most out of all my experiences during this, because I was acutely aware that stopping loved ones being together, stopping a father seeing the first blip of life in an antenatal scan, you can't get that back again. And to this day, it's the thing that I reflect on the most, I think, and with the heaviest of hearts, that I did it at the time and was able to hopefully listen and respond as more and more voices came to us about changing it. But always it was a balance between what the staff felt they could manage with in the environments in which they are working, given the lack of vaccination in the first 3 versions of the guidance. That's, we didn't have vaccines until December. So all of 2020, this was done in a time where the staff are very fearful. Did we get the balance right? I'm not sure we did all the time.
That. Is it a necessary evil, or was the balance not struck? What do you think?
Well, as time went by, we got much better at giving guidance around taking a risk-based approach. And as we started having lateral flow tests and point-of-care testing, so we knew a lot more about who was carrying disease, and having a vaccine that protected a lot more people, some of those risk-based approaches became easier to do. But in the first period of between March and December, when the vaccine came in, staff anxieties were through the roof about this. Now, I always wrote into the guidance that we needed to be as enabling as possible, particularly at end of life. The last thing I ever wanted was somebody to pass away without their loved ones having contact. And that was, even from the get-go, when we locked everything down, I always said that was something you should enable. We got more and more permissive, if you like, in the guidance, but it was only ever guidance. It wasn't you must under, it wasn't legislation, it was guidance to service, and they were allowed to depart from it.
Although it comes with that a inconsistency depending on which board, which hospital, maybe even which ward.
Indeed.
All right. Can I ask you about, I think, a change that was made in Wales, where there was a relaxation in July 2020, whereas providing the visitor did not have COVID and the visit was agreed in advance, then the visitor could come onto the ward. But PPE may need to be worn and there may still need to be social distancing. I appreciate that was an attempt to allow more people to visit, but do you think that was an onerous ask to make of people who had to, sort of the staff who had to manage the visitors? Make sure they were COVID negative, provide them with PPE, make sure they were socially distancing, agree this all across a ward. What do you think about those considerations?
Well, it's a fair point. However, I go back to saying there was still a tremendous amount of anxiety about this because we didn't have a routine testing of visitors. And I should say a word about the lateral flow test. It isn't 100% accurate. There are lots of false positives, false negatives. So it wasn't like it was a sure, fast way. If you did a swab that says you're clear. You might still be carrying the infection. And when we didn't have the vaccines, which was the case in the summer, staff were keen that if folk were coming in, they wanted to be as safe as possible for everybody, because the last thing you would want to do is either give it to the staff or to another patient or another relative visiting. So they did have to manage their environments to keep it safe for everybody.
Thinking about maternity services in particular, was it right that in Wales, women in labour should be permitted a birthing partner from their household from the 25th of March 2020? Was that the general rule?
Well, it was for them to have a birthing partner, yes, when they're in active labour. And it stayed like that in the next further 2 iterations. There's 3 iterations. That was the case.
So we heard from Dame Ruth this morning that certainly the guidance in England didn't make a distinction between active and non-active labour. In Wales, was it only allowed in once in active labour?
That's right.
Right.
The reason being it's to do with the geography, because if you are starting off early in labour, you might be in a ward with many other people. When you're in active labour, you're taken into a room on your own, so it's much easier to manage. So it was a practical, physical thing that kind of helped with that.
Were you aware of examples of women being examined vaginally to prove they were in active labour and therefore have the support of their partner?
And that wasn't told to me, and it sounds extraordinarily distressing if that was the case. Normally there would be examinations as normal part of it to
check
work out
where you are.
where you are, exactly. So I'm not sure if anybody would do it just to have their partner in. If they're in active labour, they ought to have support. And we increased the type of people can come with them. So if somebody needed extra support because of whatever issue, they may have a mental health problem or a language problem, we also said that they may have an essential worker as well as a birth partner. That came later on, because we listened to what people were saying to us.
Just standing back and thinking about the visiting restrictions, would you make the same decision next time?
Well, fortunately, I don't have to do this again because I'm retired. Should I be next year?
Were you in that position?
Were I in that
position? Would you make it again?
I think I would like us to be more permissive earlier on and find ways to do it. And I would say in particular areas, neonatal services, I've reflected on this quite a lot. I think both parents should have always been allowed to be with their child. I certainly was affected by the Bliss report that described what the impact on was having not the 2 parents seen as a unit, if you like, rather than one parent in there and the other parent not there. Neonatal care is very fraught, and often the child may not survive. So it's a very difficult area. And I think on reflection, I would have said they always should be as a pair. And other areas, I think we should have been much more careful around giving support. So if somebody's got dementia, it's a very difficult situation, and having somebody they have some recognition of. So there's lots of folk that I think we should have made more exceptions of earlier on. So yeah, I wouldn't have done exactly the same thing all over again. But hopefully next time there will be a vaccination sooner, so that we could be more confident in doing that anyway.
And I ask you please about DNACPRs. Were you made aware of any concerns that they were being issued inappropriately, or there was blanket use of them in Wales?
So I had heard from various groups about concerns about having a blanket do not resuscitate cardiopulmonary resuscitation. They came from the Disability Advisory Group that advised into government. But I also was aware from Healthcare Inspectorate Wales, which is our inspectorate body, that they'd come across one GP practice that sent out a letter suggesting to their patients that perhaps you should all consider, not all patients, but certain groups of patients should consider signing this, which is completely inappropriate. Every bit of guidance we've ever issued before the pandemic, during the pandemic, makes it very clear that these conversations should be individual, should be based on agreement with the patient and their loved ones, and about what's best for them in their care pathway. Under no circumstances, and I think Ruth may have said this this morning, under no circumstances is a blanket approach ever appropriate.
Can I ask you about an example, if that be the right word, behind your tab 15 and at INQ 30091 _9, please. Which is a note of the Executive Director's daily calls on the 3rd of April. It's probably going to come up on screen in a moment.
Okay.
There we are. I just want to ask you about the PPE box.
All right.
I know you're not in this meeting, but there was a discussion held on PPE, and specifically on ventilators. Deputy Minister has had discussions with Tai Hafan. Is that a hospice service?
It's sheltered accommodation.
Sheltered accommodation, all right.
T. Havan is...
I'm so sorry if I
That's
pronounced it
okay.
incorrectly. As their service users had received a letter from their GPs which said that if they caught the virus and were seriously ill, they wouldn't be resuscitated. And, you are in it, forgive me. You and your colleagues were working on the ethical framework.
Yes, there was a moral and ethical framework that Dr. Heather Payne and I and others worked on and issued, which sort of was to help people make the right kinds of clinical decisions in extraordinary circumstances. And it was certainly highlighted in that. But there were also subsequent letters that the CMO and I wrote out reminding people about not doing blanket do not resuscitation orders.
Did you ever see the letter? From the
I didn't
GPs
see
in
the
this
one,
example.
not that example, but as I say, I heard from different sources. That wasn't the only example I was told about. It came from a number of routes.
May I ask you about long COVID,
Yes.
please? Was any data collected on the number of nurses and midwives that reported symptoms of long COVID?
No, it wasn't. As far as I can see, the health boards would have kept their own records about staff sickness, but there was no central reporting back to Welsh Government then, or I don't think that even now that we know exactly how many staff have got long COVID symptoms, and certainly not in the time I was a CNO.
Well, I was going to ask you, did it come to your attention during your tenure?
No. I was aware that some people were taking a longer time to recover from it. So long COVID became a thing during my tenure because Welsh Government started work on setting up a framework of how to support patients and members of the population, and that would include staff members who developed the symptoms of long COVID.
Final two topics from me, please. I'd just like your assistance, please, Professor, on the impact on the nursing and midwifery profession in Wales, and starts in your paragraph 287, if it helps you. Told us about some of the support that was provided and practical help for nurses and midwives. Can you, though, give us, if it's possible, an overview of the impact on the profession in Wales?
I think it was an extraordinarily difficult time for anybody in frontline services and for the people who were managing the services, because obviously I was seeing that the senior leaders, they were having to make extraordinarily difficult decisions as well. I think it's had a long-term effect on the health and well-being of many people. We have seen people leave the service as a consequence of their experience, and because of that, we've had to continue offering a wide range of national support that has been described in my statement and my two successors, and I've touched on them before. Health Education Improvement Wales has this very large reservoir of resources that are there for people. The sort of Health for Health Professionals programme is still there. There's now a programme called Adferiad, which is a Welsh Government funded service for staff with long COVID. It has taken a much more of a holistic approach rather than a disease approach. This is about helping people's mental health, mental well-being, getting physically active again. So it's a much more rehabilitative model than a medical model. But to be honest, the legacy of COVID is going to be quite long. And obviously I'm retired now, but I see the stories about people leaving the workforce, and certainly reports like the Royal College of Nursing
Well, I was just going to ask you about that, if I may.
Yes.
And if it helps you, let me just summarise it. But I think you received a query from Vaughan Gething about a report of an RCN nursing survey in November 2020, which highlighted that 34% of staff, nurses in particular, felt undervalued by the Welsh Government. This was the highest figure of any government in the UK. And 74% of staff believed they'd seen an increase in the stress levels. I don't doubt that the Welsh Government didn't want to undervalue their nursing and midwifery profession, but the stress levels, how were they addressed?
So obviously receiving a report like that is very concerning. I was worried about the staff then, and I understand the longevity of the condition, how it's affected people's health and well-being after the surge of pandemic is now still an issue for a lot of people. And I had a conversation with a lot of my colleagues within Welsh Government about what more could we do, what more can we respond to. And as I said to you before, we already had a series of programmes of work underway to do with the mental health and well-being issue. And there was a Welsh Health Circular, which is an instruction to the health service issued by Andrew Goodall, reminding all the health boards and trusts about their employer responsibilities, about providing well-being services. So there was a pushback from us. It wasn't just Welsh Government that needed to do this. All the employers needed to do something about it. I think I was also aware that the report was part of a call to address pay and conditions. Okay. So an element of this, I had to talk to my workforce colleagues who are involved in pay negotiations. So this isn't something that Wales does in isolation. It is part of a UK pay thing, and both the UK RCN report and the Welsh RCN report also make a claim about we need to be recognised, and staff will feel more recognised if they have more pay. So I'm not trying to diminish what they're saying, because the stress was really real and the effect on their health and well-being is pronounced. I couldn't do anything about the pay, though, I'm afraid.
I think you were aware, though, of the disproportionate impact of COVID on the Black, Asian and minority ethnic healthcare workforce. And is this right? There was I think you asked that nurses took into account where they were deployed, yes, to try and presumably mitigate that disproportionate impact. Yes. Can you help us, please, with the All Wales COVID-19 risk assessment tool, yes, and how that helped that disproportionate impact, if at all?
Okay, so early on in the pandemic, the First Minister asked for a series of work to be done to look at the impact on the Black, Asian, minority ethnic population in Wales. And one of the groups that was established was to look at developing a risk assessment tool for all staff, not just people who are Black, Asian and minority ethnic. And it took the learning that we had to that point about who was more at risk. So people who are older, people who have diabetes, or and so on and so forth. So it wasn't just what ethnic group you were from. The tool was developed and issued in May of 2020, I think, 20th of May, sticks in my head. And it was sent out both in paper form and then electronically. And all staff within the system were invited to complete it and then go to their manager to say, I've assessed myself either as low risk or medium risk or high risk. It's like a traffic light system, so you could work out where you are. And if you're in a high risk group, then it's a reasonable suggestion. You should be deployed somewhere not in Frontline. I should point out that the people who are excluded from that were people like myself who were clinically vulnerable or shielding, because we expected them not to be in Frontline. In fact, not to be in work a lot of the time. The shielded people were at home. So it was designed for everybody else, if you like. That changed when the shielded people came back, so there is a second iteration of it. So I did ask to find out, so how many people from Black, Asian and minority ethnic background, staff-wise, had completed it. And you'll see in the pack there, I think, that all of the directors of workforce in each of the health boards and trusts came back to say, yes, everybody has completed this. Right. Even when the IT systems didn't quite capture it automatically, as another element of the IT systems, they were still able to do it paper-wise to track down. So everybody was able to do it. And most were in a low-risk group, not in a high-risk group.
All right. Finally, this, please. You've obviously endorsed recommendations in relation to testing and the rollout, but if you were to provide my lady with another alternative, perhaps Wales-based recommendation, what would you say would be the most important thing from your perspective that could help the nursing and midwifery profession in Wales?
I think my reflections from the time would be around infection prevention and control expertise, both in terms of every staff knowing more about it, but also having expert leadership. We really struggled during COVID to actually have people who had the right knowledge and had the senior leadership in this area. So I would say we need to invest in that pre-registration existing workforce, and I would say there should be a senior leader in each health organisation with expertise, rather than somebody who's a leader who covers infection, if you see the difference there. So that would be my first. Am I allowed a second one?
My lady, they're all the questions that I have. Is there anything that your ladyship would like to ask? Or
No,
follow up on?
Professor White, there are some questions for you that I think might take something like 20 minutes. Are you okay to come back after the break?
Of course.
Thank you very much. In which case we'll break now and I shall return at 10 past.
Thank you, my lady.
Mr Weatherby, are you asking the questions or is Miss Munro? I thought you were the one sitting there. And when I saw Mr Weatherby arrive, and it says Mr Weatherby on my list, I got confused. Miss Munro.
Good afternoon, my lady. Good afternoon, Professor. My name is Alison Munro. I ask questions on behalf of COVID Bereaved Families for Justice UK. I'm instructed by Nicola Brooks of Brady Jackson County Solicitor, who assists me today along with counsel Oliver Lewis. Just a few matters, please. 3 discrete topics and a couple of questions on each. My lady, some of which have been sufficiently addressed by Ms Carey, King's Counsel, so I won't trouble you with those. First topic, relationships with Wales and the CNOs in Wales and the other CNOs in the 3 other nations of the UK. Now, I'm mindful, Professor White, of the evidence you gave this afternoon that the role of the CNO in Wales is a substantive civil service one, as opposed to somebody like Dame Ruth May, who has an NHS role. With that in mind, could you assist us as succinctly as possible here, please, with what communications did the Welsh CNO have with other CNOs across the other nations of the UK? I know it's a rather broad question, and what I have in mind are sort of the nature and effectiveness or otherwise of those communications, please.
So each part of the UK has a chief nursing officer who gives advice to government. They have slightly different roles, but essentially that's what we do. Before the pandemic, we would meet on a quarterly basis, either in person or virtually, to help drive the professional agenda forward. Because nurses and midwives are regulated to work anywhere in the UK, we needed to have a shared understanding of what that would mean. We can't have health policies completely different because it would make it difficult for nurses to work across the whole system. During the pandemic, we just increased the amount of contact we had, partly to give peer support, but mostly so that we could learn from one another the approaches being taken in our health systems, so that good practice could be shared or assistance to find solutions. So I'll give an example, that the hospital visiting guidance, we talked about that so that we all were taking similar approach, so there was less difference geographically.
Thank you. On the 30th of March 2020, nursing directors raised concerns regarding delays in the publication of Public Health England's guidance on dealing with deaths. Why was that delay in England relevant to what was going on in Wales and decision-making in Wales?
So quite a bit of guidance around infection prevention and control was being developed at a UK level. So rather than each country going their own way, we tended to share good practice, and particularly in infection prevention and control. And we had decided that to take the Public Health England guidance and apply it to Wales in this particular instance.
So was the reality, as you saw it, that Public Health England was making the major decisions and Wales were following suit? Or was it more collaborative than that?
I think it was more collaborative than that. There can be a lot of wasted energy if everybody had to go from first principles and develop guidance. It's much better to share information and then apply it to systems if we all agreed that original piece of work was sound. So yes, it was more of a collaborative and building into application to our own systems rather than develop from scratch.
And lastly, on this first topic, about temporary registration of third-year student nurses. We heard a little bit about that this morning from Dame Ruth May. On the 17th of April 2020, in a nursing directors meeting, concerns were expressed that temporary registration of third-year students may hinder their progress and delay full registration.
Yes.
Now, a decision was taken in Wales not to adopt the NMC's emergency standards, which was placing third-year students in rostered aid employment.
That's not correct. We did place third-year students in the last 6 months of their role into paid employment. They weren't on a temporary register, that was the bit.
Right.
They were still students, and the hours they did in practice counted towards their degree. I'm sorry if the note was not clear enough. So they were paid as a Band 4 healthcare support worker for that 6 months, and they had a 6-month contract dated from the 27th of April 2020.
So in that respect, Wales was not adopting a different position from the NMC's emergency standard. I'm grateful for that clarification. Thank you. Second topic then, communications within Wales. My first question has actually been addressed. It was about the absence of a CNO role in pre-pandemic planning. That's been sufficiently addressed by you already. But my second question is this, Professor White. Do you think there was a gap in the communication between health boards in Wales and the CNO, bearing in mind the absence of a CNO role in the pre-pandemic and emergency health planning?
I had a very close relationship with the executive nurse directors. Wales is not a very large place, so we met regularly before the pandemic, and I met with them twice weekly during particularly the first wave, and then it reverted to a less frequent contact and then increased again as the second wave came along. So I wouldn't say that I had a poor relationship. It was a very good relationship, actually. Did you have a specific area that you felt that was difficult?
No, it wasn't so much about the quality of the relationship, whether it's poor, whether there were any gaps in terms of the communications.
I didn't feel so at the time, no.
I'm grateful, thank you. Last topic then. The CNO's ability to act on concerns. Now, the word concerns is something that is repeated throughout your very lengthy and very helpful witness statement. You've already told us in detail about the visiting guidance, and you were the lead in relation to that. So that takes care of my first question there. So my second question in terms of concerns is this, Professor White. At a meeting on the 10th of April 2020, concerns were raised about the deployment of returning staff over the age of 60 years of age into COVID-19 areas. And this was particularly so, this concern was raised because of the very well publicised at the time numbers of older staff in Italy that were being affected.
Yes.
What actions did you personally or collectively with others take in terms of addressing those concerns?
So that was back in April. So it was raised at a meeting with the other nurse directors. This was from Cardiff and Wales University Health Board nurse director raised it. So that practice was shared with others at that moment, but it was fed into the development of the Wales risk assessment tool that we developed for all health workers. So age on its own is not necessarily exclusive. It's the things that go with age. You often have a chronic condition like I have when you're older. So age was one of the factors that was described in the risk assessment tool that all workers were encouraged to do to work out how susceptible they might be. And that included other chronic conditions or from a Black, Asian and minority ethnic background. And in fact, men were more susceptible than women, for example. But that on its own wouldn't be necessarily a thing to move you to somewhere else. Does that answer your question?
It does. Thank you very much, Professor White. My lady, thank you. Those are my questions.
Thank you, Ms Munro. Very grateful. Now you have questions from Miss Wira Atney, Casey, who... have you got a direct line of sight?
Yes, I have. Thank you very much.
Thank you, my lady. We have an excellent line of sight. There's just a pillar between you and her, which I'm sure I can navigate.
I'm afraid we always knew that would be a problem. Sorry.
Thank you very much. I'm asking questions on behalf of the COVID bereaved Families for Justice Cymru, and many of whose members were bereaved through the loss of loved ones to nosocomial infection. You may already know that this group is critical of the Welsh Government's response to the pandemic and, amongst other things, has said that it was slow and disjointed. So I do have some questions for you remaining, and they will involve a little bit of context setting, so if you would just bear with me on that. First, I wanted to ask you about timings of responses by 3 of the Welsh Government bodies that responded. And the context of the questions is that of urgency. So on the 30th of January 2020, the WHO declared a global public health emergency. On the 4th of February 2020, SAGE confirmed the first case of human-to-human transmission had occurred outside of China. And on the 28th of February 2020, COVID-19 struck for the first time in Wales. So first question on that is from paragraph 68 of your witness statement, and you don't need to look at this. You say it was only on the 16th of March 2020 that the executive team meetings of the Health and Social Services Group to discuss issues affecting planning and delivery of health and social care in Wales stepped up frequency of its meetings from monthly to weekly. So bear with me. And then secondly, at paragraph 69, you also say that on the same date, the 16th of March, monthly Welsh nursing directors meetings increased to twice weekly meetings to share information on service issues that may require Welsh Government response. So the first question is, do you accept that increasing frequency of these meetings in key groups on the 16th of March was too slow a response to an already urgent situation?
Some groups were meeting sooner than that, so I think it'd be fair to say that the planning and response cell actually started meeting in February to start working out how the system could change. So it was certainly certain meetings were starting to step up its frequency during March. Possibly it was later than that could have been done, but I'm not sure what more we could have done earlier until we had some of the plans in place, which other groups are already working on.
So I think that I was going to ask you that. I mean, of course, I was talking about key groups in relation to the executive team HSSG group and the nursing group, which you would accept are key groups, wouldn't you?
Yes, and the executive director team meeting was weekly. So I would meet with other colleagues and the Director General on a weekly basis, usually a Thursday morning, and that was supplemented by daily contact as soon as the pandemic really started to get its claws into us.
Right. So if I was to ask you to offer an explanation for the delay in start of the 16th of March, would you have anything additional to add?
I don't think so. As the work escalated, so our need to meet more frequently escalated alongside it. I'm not quite sure whether meeting more frequently before that for some of these groups would have been necessarily helpful. Hindsight's a wonderful thing. Possibly. I don't know.
Well, let me ask you another question on that point. The Welsh Government's Nosocomial Transmission Group was established on the 19th of May.
That's right.
2020. Its role, you've already been asked about, was to provide advice, guidance and leadership on actions needed to minimise nosocomial infections. So you were the joint chair of that group along with Chris Jones. Again, referring to the state of knowledge in January and February regarding the virus as it emerged, and that nosocomial infection had been identified by SAGE in March 2020 as being a pressing issue, do you accept that the 19th of May 2020 was too slow a response to establish a Welsh nosocomial group?
Yes. Well, Public Health Wales were working on the infection prevention and control issue. The IPC cell, I think, had met in January of that year. So we were relying a lot on the expertise and support of Public Health Wales. It was decided that additional support would be needed at a government level. Possibly we could have started it a few weeks earlier, I accept that, but certainly it became a focus of our attention, and we met very, very regularly throughout my time as CNO.
Yes.
And
So
produced a lot of guidance as a result.
But you accept there was about a 6-week delay between the SAGE announcements and your group being set up?
As I say, that was because we had other mechanisms that were already in play. So this was an additional thing we added later on. I wouldn't call it a delay particularly. It was as the issue started to emerge, we realised we needed more support and a place where we could work on broader guidance rather than the immediate infection prevention and control measures that Public Health Wales already was dealing with.
But as we know, it became a pressing issue, nosocomial infection, and you were asked about outbreak surveillance monitoring, which you said in evidence came later on. Now, it's correct, isn't it, that later on means November 2020, so that's yet another 6 months after the setting up of the nosocomial transition group. That's correct, isn't it?
So what I said in my statement was that we had a pre-pandemic arrangement that Public Health Wales dealt with all outbreaks, but the way that their data was presented to us as a Welsh Government was there's some time lag. So we didn't know every day what was happening across the system. So we had to develop a way of gathering real-time data. So I would say, yes, there was a delay in having real-time data, not that we weren't actually managing outbreaks in a particular way. It just wasn't timely enough. So that would be fair to say that, yes.
Yes, because the daily reporting didn't start till November 2020, and that's the evidence you referred to earlier. So in relation to what I'm going to call slow responses at this critical time in Wales, it would be correct to say, wouldn't it, that valuable planning and response time and data was inevitably lost?
Certainly certain systems had to be established, and I would say that was slowed to happen. Some of our systems, IT systems, I think my lady already mentioned that some of them didn't talk very well to each other. So it's quite hard as a government level when you don't have access to real-time data. So that certainly took a while. We did have a planning cell that was working with the service about how to change what we were providing. So that was done in a reasonable time. I wouldn't say it was early, but it was reasonable. So it's a mixed answer, I would say to you. Some of it was possibly slower than we would ideally like, because we had to establish systems.
Thank you. I'm just going to move on to another topic now, because I only have 10 minutes to ask you questions.
Sorry.
So within your statement, you do explain that on the 3rd of April 2020, a conflict was brought to your attention by directors of nursing between the Public Health England PPE guidance and the UK Resuscitation Council guidance in respect to whether CPR and chest compressions constituted AGP, and whether in hospital settings, at least, full protective equipment should be worn, including FFP3 respirators. Do you know what I'm referring to?
Yes, I do.
So on 10th of April, you were told that practitioners in Wales did not want to use the Public Health England guidance. Can you confirm that on the 21st of April, you received an email from one nursing director of a local health board alerting you to the fact that some health boards were insisting on accepting the Resuscitation Council position over that of Public Health England?
Yes, it's remained quite a contentious issue within the service for a number of months. It wasn't just that one instance. We talked about it multiple times as executive nurse directors. And in the end, the CMO and I actually put out what we hoped was helpful guidance to find a way through while the scientific experts looked at the issue. I'm not an expert in this area. So this became a problem for some months. And eventually an aerosol generating procedures specialist group was established at the request of the senior
I'm
clinicians.
going to interrupt you if you don't mind me. There was a specific line of questioning that I wanted to follow.
Okay, go ahead.
But I want to be fair. On the 14th of April, you did issue a letter, which is in your statement at paragraph 208, I believe. You've set that out there. But I just wanted to ask you this. So you did receive that. There was an insistence on the part of some local health boards to use the RCUK guidance. Mm-hmm. And you forwarded that, didn't you, to Frank Atherton, then the CMO of Wales, and also to Chris Jones, the deputy CMO. And you stated, in quotes, "As I said before, I wonder if we should have made a decision to just accept the Resus Council position as best practice for Wales, given the level of distrust now apparent within the PHE-PPE guidance." Bear with me. The response you received from Chris Jones was that it was not for the Welsh Government to mediate the standoff between the RCUK and PHE, that the Welsh Government supports the PHE guidance, and that it was for organisations to consider what advice they wished to adopt. And Frank Atherton said that there should be no further action. So my question is this: do you agree that further action should have been taken to provide clear leadership in respect of the PPE guidance to be used in Welsh hospitals on CPR, during CPR?
So Frank and I did actually send a letter, I think it was about a week after that, which tried to mediate a way forward while the issue was being sorted out. So this needed to have further scientific view on it. The whole issue about whether chest compressions causes aerosol particles to a degree that would actually cause a risk to staff. So we tried to be helpful, but it wasn't really Frank or I's place to try to sort out the scientific argument that was going on.
So do you accept, though, that the argument, if you like, was causing confusion on the ground?
It did.
And that patients and staff were at risk as a result?
Probably.
Yes.
I mean, all I can say is we tried to find a way with advice to mitigate the risk, but certainly having the confusion added to a distrust of guidance that was coming out, and that was not helpful to anybody.
So that was my final point on this, in relation to the distrust of guidance. And my question is this: did this attitude of distrust by the local health boards spill over into other aspects of PPE guidance and damage the confidence in Public Health England's guidance and compliance by hospital staff in Wales?
Possibly, but it was not reported to me as an issue as clearly as this. This was, I would say, the standout conflict between advice that was given to staff. It may very well have made people question what other guidance was out there, but it needed to be clarified to help. So I can't give you another example, I'm sorry.
All right.
Thank you.
Thank you very much. Those are my questions.
Thank you very much. Thank you very much indeed, Professor Wright. I'm really grateful for your help. I don't know if it's pleasant meeting your former colleagues in this situation when you've all got to relive such a dreadful time. But anyway, thank you for coming along today.
Thank you very much, my lady.
Thank you very much.
Ms. Carey.
May we now hear, please, from Mrs. Fiona McQueen, who's just coming in.
Right. Would you like us sworn?
Yes, please.
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
You've been waiting a long time. I'm very sorry.
It's not a problem, my lady.
Mrs. McQueen, your full name, please.
Fiona Catherine McQueen.
I think you were initially the interim Chief Nursing Officer in November 2014, became the Chief Nursing Officer then until February 2021.
That's correct.
Can you just help us, please, with your own professional background? Just summarise that if you...
So I essentially am a generalist nurse leader. I became an executive nurse director in 1993, so the bulk of my clinical practice has been in nurse management or executive nurse director roles. So generalist leadership across a number of areas.
I think you are... the Chief Nursing Officer has its own directorate, which sits within the DGHSSC, or the Director General of Health and Social Care in Scotland.
That's correct.
And your roles and responsibilities are set out in your statement, but they include providing policy and professional advice to ministers and leading on professional and policy aspects of healthcare-associated IPC and antimicrobial resistance measures.
Yes.
A mouthful, but is that it in a nutshell?
That's it.
All right. You provided advice to a number of groups, I think, during your tenure as CNO Scotland, including the Health and Social Care Management Board. I know that was briefly reconstituted to be called, I think, the Health and Social Care Planning and Assurance Group before going back to the board. Is that right?
That's right.
Just tell us, what was the board's remit?
Essentially, within Scotland, the NHS is run by NHS boards from a legislative perspective, and the Director General is also known as the Chief Executive of the NHS in Scotland and the Accountable Officer financially. And the Director General has a team of directors, including the Chief Nursing Officer, and we would oversee policy on health and provide advice to ministers, but also look at enabling that policy to develop into strategy for delivery of the NHS.
I think one of the other advisory groups that you either attended or was associated with the CNO and the Directorate was the Covid-19 Nosocomial Review Group, or CNRG as it was known. Was that something that you set up alongside the CMO in Scotland?
Yes, in Scotland I think we have a very effective national group. Now, over March to April 2020, Health Protection Scotland, we had the creation of Public Health Scotland and Health Protection Scotland, which was NHS RHI, the derivative of that. So sometimes HPS and NHS RHI are used interchangeably. So we had a good system in Scotland for oversight of nosocomial infection, antimicrobial resistance, and that was there. Obviously, during the pandemic, there were other bodies nationally across the UK that were set up. But I wanted, after a few weeks, I realised there was a gap, and I had wanted to have a more expert group who could look at what was happening in SAGE, look at what was happening internationally, and provide advice to myself and Gregor Smith, the CMO, and we could then onward to ministers or into the service. Just wanted something that was more locally applied to Scotland, more responsive to our questions and our direction, and able to formalise what was happening within Scotland.
And I think you said in your statement that group first met on the 7th of May in 2022. And if I understand it right, are you actually a member of the group, or do they report to you?
They reported to me.
Right. And the CMO
yes.
as well? All right. Were you involved in any advice giving to ministers between January and March 2020? Sort of the pre-pandemic phase.
With regards to IPC or in general? In general. No, a lot of that was done by the CMO, the Cabinet Secretary for Health, and the Resilience Unit did a lot of that work. But we were beginning to ramp up in terms of looking at the student nurse, our senior student nurses moving into employment, similarly with the ITU guidance. So I wasn't involved in the national advice that would be happening nationally across Scotland. It was more bespoke with regards to the nursing and midwifery workforce.
Fine, thank you very much. Can we look at the CNRG in a bit more detail, please? And I think, if I understand it correctly, it was there set up to try and understand nosocomial infections and identify any other IPC measures that might be needed to try and combat those infections. Is that right?
Yes, I think it's important to clarify nosocomial infection exists, unfortunately. It exists right across the world, and it's a well-known phenomenon internationally. Also, when there is circulating infection in the community, then the people who are in the community bring that into institutions. It's easy to see in the winter vomiting bug when we see the norovirus coming into hospitals or care homes over the winter, which is why visiting can be suspended for particular wards or departments. So I think the understanding of nosocomial infection is quite clear. But what we wanted to have was additional advice from a group on, in particular, because we're not normally, in normal times, you don't have the infection being brought into the organisation. So needing to have advice about how it was travelling through the organisations, what was happening with staff, and giving advice particular to COVID-19. and we very quickly published cluster information and minutes of the CNRG as soon as we could.
I think you said you published the minutes, but did you publish the recommendations that the CNRG made?
So they would be summarised in the minute.
Right, okay, thank you. And you say in your statement that the CNRG's advice was provided to you and the Chief Medical Officer, and thereafter you and RHI considered the advice and used it to inform policy development. Can you give us an example of what practically you did as a result of CNRG's advice?
So a bit of context as well. Within my directorate, I had policy civil servants as well as clinicians who worked in what we would call the HAI team. The chair of CNRG was also the nurse director of NSS, so was associated with RHI, and there were members of NHS RHI on CNRG. So to say it then went to RHI is correct, but there was a lot of commonality amongst that. Things like whether or not to test staff in high-risk areas, whether or not to look at testing. So one of the early pieces of advice it gave us was where you have an unusual or even one member of staff testing positive for COVID, or a patient testing positive for COVID in a ward, an elective ward, which was not a COVID ward, they recommended testing patients and staff.
You mentioned testing, and I was going to ask you, please, about paragraph 28 in your statement, where I think you say that there was advice from the group to the Directorate in late May 2020, for additional targeted healthcare worker testing to protect highly vulnerable patients in hospital at risk of poor outcomes from acquiring COVID-19. Who were the highly vulnerable group that were being spoken of there?
So this is against the backcloth of testing capacity not being what we would want it to have been. So oncology patients, so inpatient oncology patients, including those who are having chemotherapy, if chemotherapy had started back by then. I know we suspended it for a short time. Care of the elderly, so our frail elderly wards, and also our our wards where we had long-term mental health patients for longer than 3 months. So we thought, the advice from CNRG was, this was a group who were particularly vulnerable, and therefore we would look at testing staff on a weekly basis.
What about those with dementia? Were they as part of this group or not?
So that would be, I do beg your pardon, Ms Carey, that would be part of the older people's wards.
Right, understood. Thank you very much. Can I ask us, please, to have a look at INQ 250382? And Mrs McQueen, it's behind your tab 3, but it might just be easy to look at it on the screen. This is a note from you to the Cabinet Secretary in June of 2020 on the 3rd in relation to healthcare worker testing in hospitals. And you can see it's to propose an approach for healthcare worker testing for COVID-19, further to the advice of the CNRG. And I think that we can see the background to this is asymptomatic transmission and testing. And at that stage in Scotland, only healthcare workers who were symptomatic were tested. And the proposal was to test more to try and identify those who may be asymptomatic. Is that it
That's
in
correct.
summary?
Yep.
Right. And I think you say there, I might just need your help with this, at paragraph 4, latest analysis finds that approximately half of the cases in all of the reported NHS Scotland cluster outbreaks in non-COVID wards are healthcare workers. Can you help us with a cluster outbreak? How is that term used in Scotland?
So the term cluster and the term outbreak are both used epidemiologically within public health and within infection prevention and control. An outbreak would be 2 or more cases where there's a common source, and a cluster would be 2 or more cases, not necessarily needing that common source.
Okay.
So it's an outbreak is a subset of a cluster.
Yeah, thank you very much. And so here, at present, almost 70% of cases in the active clusters are healthcare workers, And then the 6 active incidents involved 26 patients, 59 members of staff. The 118 closed incidents. What's the closed incident a reference to?
It's where the cluster or outbreak has been deemed to have stopped. So no more new infections and not being actively managed.
So it had historically been the position in Scotland there were 118 closed incidents involving the 888 patients, 213 deaths.
Yeah, at that time.
And 862 staff cases. And I think if we just go to page 2 in that document, at paragraph 7, top of the page, thank you, there was some work done on mathematical modelling, which estimates that the weekly screening of healthcare workers could reduce onward transmission from healthcare workers by a further 16 to 23% on top of self-isolation. Although that was an assumption, essentially here, were you asking the Minister to bring in testing for the asymptomatic healthcare worker?
No, I think we weren't asking that as a blanket way. I think the recommendations are in under paragraph 11.
Yep.
I think what we were saying is where there's an unexpected cluster or outbreak, we would want to look at that, and where the infection prevention control teams believe they needed to do that they would do that as well.
So you were wanting to target testing where there were these unexpected clusters or outbreaks. Is there any reason why it wasn't wider and just an implementation of asymptomatic testing across the board?
So I'm not sure if it was close. So we would brief the Minister post CNRG or post something new happening. And I think the Imperial College presented a paper that talked about the value of asymptomatic testing. Now, CNRG looked at that, and their view was it was a theoretical or abstract piece, but in the real world, good infection prevention control measures would actually be more effective because it would reduce nosocomial infection by 80%. And their advice at that time was not to blanket test asymptomatic workers. My sense is if we had had the testing capacity, we would have been there.
Well, that's what I was going to ask you. So there is, if I understand your evidence correctly, there was an evidence-based decision taken not to roll it out more widely. Was that the driver of the decision, or was it the lack of testing capacity?
I think if it had been only a lack of testing capacity, then the briefing that I would have had from CNRG and my team that I would have given to the Minister and I would have talked to Gregor Smith about was, we don't have enough testing to do this. Is it a priority, and how can we possibly do that? So I think it was an on balance. Actually, it may not be productive, and good IPC measures are important with the testing where there are even just one unexpected case. Now, that didn't last because we then moved, I don't think that lasted, because this was before the end of June when we were starting to do the vulnerable patients, I think. So I don't think it was predominantly because there was a lack of testing capacity, but there's no doubt at the early days of the pandemic, lack of testing capacity was a problem.
I don't know if you heard any of Dame Ruth May or your Welsh counterparts' evidence, but they have both spoken to Her Ladyship already about the role of testing. Did you hear any of that evidence whilst you were waiting?
I did hear on and off both Ruth and Jean, but I don't remember testing because I was travelling across London at times.
They both advocated, in short, for an increased amount of testing to help with visiting restrictions and the need for it or otherwise, prevention of nosocomial infections. Do you have any dissent or assent to their views?
Complete assent. Increased testing would have been enormously beneficial, I think, right across society, but since we're here to talk about health, within our health system.
Yeah. Different aspect of CNRG's work, please, in relation to face mask guidance. And Mrs McQueen, it's at your paragraph 35, and I may need to put up on screen the table that you've set out in your statement. Could we have, please, 474-225_13? And think really you've set out a timeline there of the changes to the face mask guidance that was brought in various stages in 2020. June 2020, there is introduction of interim guidance on the wider use of face masks, decision to introduce the face mask in adult hospitals and care homes for the elderly. And the reason for the change is set out there to help reduce nosocomial transmission in hospitals and care homes. I presume we're talking about FRSM masks.
Yes.
That guidance in June 2020, did that include people working in non-clinical roles?
No, I think that was the non-clinical roles was in September 2020.
Yeah.
It does seem curious now that it didn't, but no, it didn't.
Do you think now you would make a distinction between those in clinical roles and those in non-clinical roles for something as simple as an FRSM?
Absolutely. For something as simple as an FRSM, and knowing now, and it is always difficult to move us from where we are today to where we were then, and knowing now what we know about ventilation, about air throughput, and about transmission, I think it would have been better if we had that as early as possible.
September 2020, as you rightly pointed out, updated face mask guidance to cover now primary and wider social care. Primary care including GPs, practices, dentists, opticians, pharmacies, and the wider community care are set out there. Can you help as to why GPs and pharmacists weren't included in the rollout in June 2020?
So they would have been wearing it in patient-facing when they were seeing patients, but not when they were perhaps in the staff room or if the pharmacists were in dispensing areas. So it would be the non-patient facing roles then as well.
Okay. And if at the bottom of the screen we can just see there June 2021, a year on from the initial introduction of the interim guidance. Now we've got wider FRSMs by clinical and non-clinical staff. So is it right that a year elapsed before the recommendation was for non-clinical staff to wear FRSMs?
So by that time I had demitted office at the end of February 2021. So I apologise, Ms Carey, I would have thought from memory that we introduced FRSMs for non-clinical staff earlier than that, but I could...
You think it happened in your tenure?
I thought it did, but I may be wrong. Because there's no... And so when we talk about clinical staff, if you were part of the trades workforce, and that would have included them going into wards and departments in the June 2020.
It's my fault. I'm not familiar with the trades workforce. What do you mean by that?
Well, plumbers, electricians, engineers.
Yeah, okay. If I understand you correctly, though, for the porters, the cleaners, people in that non-clinical role within the hospitals, though, when do you think they were advised to wear FRSMs?
So I think in September. So I think in June 2020 we would have been looking at the introduction for all staff. So we weren't just saying clinicians. So anyone who was in a ward or department, which would be the trades workforce, or cleaning staff, or catering staff, as well as doctors and nurses, would have worn that. But in the workshop, the trades workforce may not have in June 2020, but they ought to have in September 2020.
Okay. Dealing with guidance, but in a different sphere, can I ask you about the IPC guidance, please? We can take that down, thank you. I think, is this right, that Scotland followed the UK-wide IPC guidance, but in October 2020, Scotland published its own COVID-19 specific guidance. Is that correct?
In terms of IPC?
Yeah.
So it would have been a Scottish version of it.
Right. That's what I was going to ask you. Did it replace the UK-wide, or did it supplement the UK-wide IPC guidance?
So I struggled with the UK IPC guidance because, and the feedback we got from staff was, it was confusing going on to
to have a look online, because the National Infection Prevention Control Manual that we'd had in Scotland for some time was an online manual. And staff were used to going online to check what the most up-to-date guidance was. And then they were sent through to Public Health England. And at times that may or may not have had everything that was relevant to Scotland. So I was always keen that we had very clear and explicit communication for people working within the Scottish Health Service and social care.
So although the UK IPC guidance was designed to try and standardise position across the UK, in fact, did it serve to confuse in Scotland? Is that really where you get to?
Yes.
Okay. You do say in your witness statement that there was 15 times that guidance was issued on a Friday. Was that IPC guidance or guidance across other areas?
I think that the IPC guidance was particularly problematic, and particularly because realistically, NHS and the civil service were working 7 days a week. So in a way, whether or not it was issued on a Friday was kind of immaterial. But smaller, in social care, we had much smaller organisations who had less resource, who struggled with information coming out on a Friday. So I think there were other issues other than IPC guidance that would be issued on a Friday as well, other health workforce issues.
Did you become aware of concerns, though, about it being received, in theory, late in the week, albeit?
Definitely, and it wasn't ideal, but the question was, do we hold it until, because we weren't going to issue it on Saturday or Sunday, do we hold it till Monday, or do we issue it and give people time to get it in place? We didn't criticise people for not having immediate implementation, because some of these things would take a number of days to take over and implement.
Can you think of any way to try and, if there is a concern about it coming out on a Friday and saying it's got to be in place by Monday, is there anything practically that you think could or should be done to try and soften the blow, if I can put it like that?
I mean, I think resourcing is an issue. So in reality, coming out on a Friday, I may be wrong, but I'd be surprised if we said this is for implementation by Monday, or there'll be firm words taken. I think we would have said, as soon as you can, could you implement this, please? And we would often give a bit of time for things to be implemented, depending on what it was. If it went to an NHS board, our biggest NHS board has over 20,000 staff, so that's never going to reach the front line in anything other than a matter of days.
And generally, in relation to the IPC guidance, we've heard that there was the UK IPC cell with representatives from Public Health Scotland on it, and all the other public health agencies and a number of other bodies. What role, if any, did you have in approving, amending, disagreeing with any guidance that the IPC cell wished to have published?
So I'm a generalist in terms of my leadership skills. I'm not an infection prevention and control expert. I had policy, but in particular clinicians working in my team. And I relied completely on NHS RHI. So if they came and said, this is a guidance that we believe we should be implementing, I may have asked questions and I may have queried parts of it so that I could have a better understanding of how that guidance was formulated before I then advised ministers. Because I was not going to have NHS RHI saying, Fiona, I think we should do this, and then me say to the minister, I don't think we should. Right. So I was relying on the clinical experts in NHS RHI and also my policy team to advise me.
Can you ever recall an occasion where you disagreed with the guidance that was coming from the UK IPC cell and pushed back, I think, to use the popular phrase?
So in the early days, when I was unaware of the IPC cell, I think it was late March, because it was the 2nd of April guidance that was being worked towards. My team alerted me to the IPC cell developing guidance. And in Scotland, we have a heavy, not just tradition, our working practice is to work in partnership with the trade unions and the professional organisations. So almost anything that we develop in partnership. And it's in partnership rather than develop it and then consult. And the Royal College of Nursing were concerned because they had not been involved in the development of this guidance, and they had concerns about access to fluid-resistant surgical face masks for some staff. Now, at that time, and again, it seems very strange to think back to when we would ask clinicians to go into, and it was particularly in homes, into patients' homes, and not wear an FRSM. But that was the guidance at the time. If your client or patient wasn't displaying symptoms of COVID and didn't have COVID, you didn't need a face mask. And so my team had signalled to me there was real concern here, because there was a UK body or a UK group trying to develop guidance, and it wasn't listening. So I became involved then, and after that there were 4 tables in that guidance, and table 4. So there was table 1, 2 and 3, which outlined what happened when you either suspected someone had COVID or someone had COVID. Table 4 was where there was high levels of circulating virus in the community, and the member of staff believed they would be better and safer to wear a mask. And that's when we insisted on moving to have a wider level of guidance. Right. I think there was also another time when there was a safety alert, a CAS alert that England had issued, NHS England had issued, that had appeared on the UK website, and I advised my staff that could not happen. We needed to have either completely UK or we just go back to the 4 country. So that there were times, and similarly with a letter I wrote in May about AGP and or not of CPR and whether or not staff could wear FFP3 masks on that. I had a discussion with Gregor Smith, the CMO, and we issued a letter to say if staff want to wear that, then they may.
Yes, I think you set some of that out at paragraph 55 in your statement. I won't take you to it, but it in short was the position in Scotland that if staff wanted to wear FFP3 during CPR, then they could, even though that wasn't necessarily the recommendation that was coming from Nerve Tag and perhaps the UK-wide guidance.
And before doing that, I talked to, so I was hearing concerns. I talked to the IPC team because I didn't want to be seen to be trumping them, and I wasn't saying this was IPC advice, but cardiopulmonary resuscitation is such an emotional response as well as a physical response to try and save your patient's life, and I just didn't think it was worth arguing about whether it was FRSM or FFP3. I thought it was better to give people as much support as we possibly could.
Can I change topic slightly, please, and just ask you about the temporary register? We know that certainly by April of 2020, the figures of those returning to the temporary register were broken down nation by nation. And could we just put up on screen INQ 421 170 0004, please? Well, we've looked at this now with your counterparts, and I just wanted to look at the Scottish position. So by the 21st of April, there were 1,272 nurses and or midwives going back onto the register in relation to Scotland. And the question really for you is, how many of those were actually deployed to the front line? Do you know?
So I don't know, but I think anecdotally not that many, because remembering a live registration, we revalidate every 3 years. So somebody could almost be 5 or 6 years out of practice when they come onto the temporary register. And I've already heard evidence from my 2 CNO colleagues about choice. So people may not have wanted to go to the front line. And we certainly used people on the temporary register or the other, well, we also had returners within the vaccination centres. But I think there was something about need and demand, so whether or not NHS boards actually needed the additional staff, and in many cases they didn't, and then whether the additional staff wanted to do frontline work or whether there was work that they could do. So, and also, I think there's learning. The onboarding process, although Scottish Government paid for their PVG checks and tried to facilitate it, the onboarding took longer than was helpful.
So happily, you say the boards didn't need the staff returning to the register, but the bottom line is you don't know how many were in fact deployed to the front line. Do you think that kind of data would be helpful or not in the case of Scotland?
I think it would be helpful. I think you have to have a balance between, depending on how good your electronic systems are. If you had good electronic systems, at the press of a button, if you could find out, well, 300 went to the front line, but it would have been adding more bureaucracy and more paperwork to already hard-pressed clinicians and managers. So I think in the future it would be helpful to know, but I didn't feel bereft because I didn't know.
And I think you said in your statement at paragraph 108, I'll just read it to you, you said, I was not aware of issues and concerns regarding the lack of relevant training, the suitability of roles to which staff were redeployed, and or support for redeployed staff, nursing staff and midwives. So no concerns were raised to you about those either coming back onto the register or being moved from one department to another?
No, I'm not saying they weren't there, and concerns would be raised to me in a variety of ways, particularly through the nurse directors who I met with on a regular basis, who would signal things, but also anecdotally things could come up, but I wasn't aware, no.
Did you ever have discussions with someone like the TUC, or the Scottish TUC, I should say, about concerns about those who are being redeployed?
So I wouldn't have, but probably twice a week. So the health workforce, so I was a director of health workforce who would take the lead on workforce issues, and she would convene meetings probably twice a week, and one of my Deputy Chief Nursing Officers, Diane Murray, would be at that, and that would be whether it was the Royal College of Nursing, Unison, Unite, that would be brought up there.
Can I ask about a different concern that may have been raised with you in relation to the fit of PPE and around face fitting, and particularly in relation to ethnic minorities and the like? Were concerns raised in that regard with you?
So concerns were raised, so even predating the pandemic, there was always a niggle about face fitting, and everyone should have had face fitting. It was something that was sometimes tricky because people didn't see the immediate need to have an FFP3, so actually going to be face fitted was not necessarily high in their priorities. So even before the pandemic, I was aware of the fact that face fitting was not universally carried out, and there were times when the size of the mask, the type of the mask didn't fit. That clearly was highlighted during the pandemic, and so both for when I say the shortage, the lack of supply meant we were having to source internationally, so there were a number of different masks which would need to be face fitted for different people. So it was a huge exercise, but yes, I think facial hair, Black, Asian, minority ethnic colleagues and a lot of women as well would have trouble with that.
In relation to Black and Asian and minority ethnic nurses and midwives, were there any other major concerns, or what were the major challenges facing them, I should say, as far as you were made aware?
So I think the real worry of what was the impact the pandemic was having on the Black, Asian, minority ethnic community in terms of, and there was a lot of uncertainty at first. This was a new virus. We weren't quite sure what was happening, and was there a greater death rate or not? And in the early days of the pandemic, it was difficult to be definitive about it. So I think there were aspects of morbidity and mortality who was going to be affected more by the virus, as well as then physically in work, not having the right protective equipment. So there was a suite of measures, which I think is why there was a response in May, Scottish Government, but my sense is we probably all did this roughly the same time. Was
May 2020?
Yes, a risk assessment. So where we issued an instruction to the NHS in Scotland that every member of staff from Black minority ethnic communities should have a conversation with their manager, which should be a supportive conversation, and within that have a risk assessment where they could talk to them about, did they have any other predisposing conditions, how did they feel about being, whether they were on the front line or not, and did they want to be redeployed? Did they have the right level of PPE or not?
In your witness statement, you set out the chronology of changes to various bits of guidance, and essentially by April 2022, there was, I think, a letter issued setting out responsibility for ensuring staff were given access to FFP3 masks based on their personal preference, and not in response to a risk assessment or IPC guidance, but if they wanted it to make them feel safer at work. By April 2022, that was a stance that was being supported by the government. What do you think about that having been brought in earlier, and should it have been?
So that, of course, was after my time as
CNO.
I think the whole precautionary principle piece is one that is important to explore. And the IPC were very keen to be particular, and I think it's important to say and describe what PPE is appropriate for keeping people safe. So I think you do need a standard, and you do need to have that rigorously implemented. If people start wearing different types of PPE, whether it's higher or lower protection, there are a number of factors. It can wane public confidence. It can cause difficulties. But I see now, it's in the National Infection Prevention Control Manual Act, when I was refreshing to come here, I see that last month, under transmission-based precautions, there's work going on, which is looking at the definition of aerosol droplet and contact. And the problem I think we had was it was very linear, and it was either FRSM or FFP3. People were, in a way, defending their corners rather than trying to find the best possible solution. And because of that, I think we've been blinkered. Now, there may or may not be unintended consequences of wearing FFP3. For instance, there's an increased level of carbon dioxide within the wearer's blood. We don't know. But now, if you're working in high consequence infectious disease, such as an intensive care where there were aerosol generating procedures, then these staff were wearing FFP3 for 12 hours.
Yeah.
So I think it's something we would want to be exploring anyway. And I think, given where Gregor and I were in May of 2020 saying, if you're carrying out CPR and you want to wear an FFP3, then wear it. I think I would have wanted to have at least the dialogue. So one of the difficulties of being out with the healthcare system now is I miss having colleagues to talk these things through with. And the unintended consequences of having that more on the health and well-being of the workforce who's wearing it, because if the employer is saying you may wear FFP3, then we need to be aware of the risks that would entail for the member of staff. So that's a long answer to say, on balance, I think an earlier discussion would have been helpful.
Well, it will resonate with evidence we've heard that Her Ladyship's been hearing now for the last few days. Can I deal with some topics very briefly, I'm afraid? And I mean no disrespect to you for the lack of time that we've been able to afford you today. Inspections. Yes. They, I think, were stopped initially in Scotland, and you asked them to be reinstated. I think it was on the 30th of May 2020. You reinstated what's called a combined safety and cleanliness inspection and an older people acute hospital inspection. Why were you asking for them to be reinstated, and what were you expecting them to try and ensure didn't happen?
So part of the CNRG work influenced me to think through how can we keep our vulnerable people as safe as possible. And therefore we stopped the inspections so that we weren't intruding into difficult times delivering care. We wanted to redeploy clinicians who were involved in inspections, and we stopped them in March. So I was concerned about nosocomial infection. Our inspections, I think, signal and flag up some very helpful areas for improvement, and therefore the programme of work that I agreed to was looking at settings where our more vulnerable patients would be. So community hospital, older people's hospitals, and the inspections that we had there certainly highlighted areas where practice could improve and reduce nosocomial infection.
Different topic, DNACPRs. In your time as Chief Nursing Officer, did you become aware of any instances of inappropriate use of DNACPRs or blanket use of DNACPRs?
So there was anecdotal evidence of GPs writing to, going into care homes and saying, well, we'll have a DNACPR. Now, anticipatory care planning is important, probably for all of us in this room, never mind older people as they get nearer the end of their life. So it is something that should be done, but done sensitively and done in partnership with that person and in partnership with the families. So a letter, I think, went out from the CMO in March, and that, I think, caused distress. All it said was make sure your ACPs were in place. It didn't say anything else. And out of that, we developed what is in my statement, Care Home Professional Advisory Group, where we set up a group that was co-chaired by my DCNO and one of the senior medical staff in CMO's directorate. In that, we had patients' representatives, we had social work, social care, we had the chief executive of a social care organisation there, so that we could develop comprehensive guidance for social care. So I'm aware anecdotally, under no circumstances should it ever have happened, and I think we put mechanisms in place in Scotland to prevent that from happening.
I think during your time in post, you said you were not aware of any work specifically undertaken to support nursing and midwifery staff with long COVID. That's clearly an impact on nurses and midwives. Can you summarise from your perspective the impact of the pandemic on the nursing and midwifery profession in Scotland?
So going into the pandemic, we had been strengthening the nursing workforce. We had been increasing the nursing workforce. We'd been increasing undergraduate nurse places. We had been investing in GP nursing workforce, over 200 additional school nurses. So going into the pandemic, and we also had developed legislation which was set in a statutory footing the number of nurses in a ward or department, and along with a wellbeing requirement for employers to make sure that they were measuring and supporting wellbeing of the workforce. The pandemic was relentless, and it's affected probably every single person in society, but I think that the nursing workforce, and I'm incredibly grateful to them all who stepped forwards, has had a real impact. Some have been exhausted, others have been rejuvenated and found new areas that they want to work in. But I think having the right number of nurses, we did have a wellbeing hub, so we invested in the May of 2020, having wide support mechanisms for nurses. In fact, we also, for all staff, National Education Scotland also have now are recovering from the pandemic, so they have a wellbeing section on their website which is to support health and wellbeing of nurses. And my daughter was one of the student nurses who was deployed to the Frontline, so I was well aware of the impact that had on the whole workforce. So I had briefings every day of what was happening and the devastation it had caused, the death that they saw that they should never have seen, and the work that people have done. And I think as a society we need to be incredibly grateful. But I'm confident and hopeful that the nursing workforce will move on and be stronger as a consequence of this.
Well, with that sense of hope, can I ask you finally this, please? Aside from joining the call for better testing and greater testing capacity in the event of a future pandemic, do you have any other recommendation you would make to Her Ladyship that would really practically, you think, help the response and help nursing and midwives in Scotland? I think capacity, with surge capacity, is going to be really important, because I think we were caught in the hop in terms of we needed to cancel, and you would cancel with a new virus circulating. You're going to cancel elective work until you see how the virus behaves. But I think making sure you have enough capacity in the workforce
the nursing workforce is iller and have more chronic conditions than the population in general. So I think looking at the health of the whole health workforce, but also having physical capacity, physical space and physical capacity, so that you have surge capacity and you can move patients. You don't need to move patients for space, that actually you have a sufficiency of space to care for patients. And just one other, I think, small thing. We had retire and return gave us more capacity for nurses when we had that within the pandemic. But at that age, the normal pension age was 60, and nurses could retire at 55 without actuarial reduction. The next pandemic, the normal pension age is going to be at least 65. So we will not be able to, I don't think, rely on nurses returning the way we did this time. And I think that's where a lot of our additional workforce came from, rather than the temporary register.
Understood.
So.
My lady, those are all the questions I have. I know there are some questions from core participants. Is there anything your ladyship wishes to ask?
No, thank you very much. Ms Mitchell, that away.
Okay.
And I do give permission for you to swap the question, Ms Mitchell,
I'm
in case there was any confusion. I think
I'm obliged, my lady, that's helpful. I appear as instructed by Amar Anwar and Company on behalf of the Scottish COVID bereaved, and there are just a short number of questions that I would like to ask you about. My learned friend counsel to the inquiry has already taken you to paragraph 35 about the face mask timeline, and we saw from that in June 2020 there was a wider use of face masks. You have also commented in your evidence about noticing after a few weeks that there was gaps in the expertise that you might need, including what was happening internationally. And I want to ask you quite a simple question, really, about face masks in healthcare. When we were watching the experience of healthcare workers abroad and the unrolling of COVID, we saw in those healthcare settings in China and in South Korea, where they had dealt with SARS and MERS, we saw in those healthcare settings the use of face masks from the start. And I suppose my question is, given that we didn't know what was the method of transmission that was most likely, ought a protective or preventative approach have been used and a decision been taken, we should use masks immediately until we know the methods of transmission? Could we have learnt from watching your colleagues abroad and implementing that as a precautionary principle?
Ms Mitchell, I've already, I think, said to Ms Carey, I think one of the difficulties of being out of the health workforce is I don't have colleagues with whom I can have a meaningful discussion who could perhaps caution me or about some of my thoughts. But the whole precautionary principle of going in at a higher level of protection would make sense to me, having looked back on what we had. I think the view was it was droplet transmission, so I think we very quickly came to a view. I think throughout the pandemic we've looked further. So I think
Sorry, if I may stop you, we understand the progression that was made. It was really whether or not it would have been a good idea to, at a very early stage, to have some ability to look internationally, to speak to colleagues across the various different countries where they had already experienced respiratory problems, and to have that expertise right from the very start and implement it.
So, Ms Mitchell, I do think so. I think our NHS RHI and the IPC cell would say that they have looked internationally, but I do think some of the countries who've experienced pandemics in a different way from us have the wisdom that we should perhaps be learning from.
I'm obliged. Moving on, can I ask you, you explained what your area of expertise is and then when you took guidance from others, did you understand, having received guidance or advice, that transmission routes, droplets or aerosols, rarely function in isolation, i.e. where you have one, you will have to a degree another? And if so, if you understood that to be the case, did you report or advise the need for multi-intervention approach? And if so, to whom?
So the advice I was given was it was droplet, and I don't think for me the question of the aerosol piece would be coming from where aerosol generating procedures were carried out rather than routine day-to-day areas where they were not carried out. So it was not in my conscious level that the mixed mode, which I think I talked about the NIPCM and the work that's going on just now, which I would welcome to make it clearer what's happening. So at no time was I of the view that there was aerosol contamination whereby staff needed to have FFP3 protection, and I took no action.
So can I just be clear about that? Are you saying essentially that what you were thinking was this is a droplet route, and therefore you weren't really considering the issue of aerosols unless it related to the carrying out of something that would produce aerosols per se?
That was the advice I received.
Moving on to another question which my lady has granted authority for. Earlier on in your evidence, you were talking about PPE, and you said that when talking about PPE, you indicated that you were having a shortage, and then you corrected yourself and said the lack of supply. And I want to ask you a little bit about that. In particular, your comment at paragraph 135 of your statement. I don't need that brought up. But it said, neither I nor my directorate were aware of any shortages in PPE or RPE for nursing and midwifery staff, but we're aware anecdotally of issues in supplies not being easily available to staff in some instances. Now, I just sort of want to break that down, because from the evidence that we have heard from various bodies, and indeed I think a comment my lady made to Jean Freeman when she gave her evidence earlier on about shortage and supply, it might come as a surprise that people hear you say that neither you nor your directorate were aware of any shortages. Are we really talking about the difference in emphasis and language? If there were issues of supplies not being easily available, presumably the people on the ground floor would see that as a shortage.
So I probably haven't been clear enough, and the language choice of my statement I think could have been better. My understanding is if I maybe talk, I don't know if I'm allowed, my lady, to talk about social care separately, because
I'd rather you.
okay, if we talk, that's fine. If we talk about the health system, my understanding that every single person who needed an apron, a mask, a pair of gloves, a gown, got one, and there was a heroic effort from managers moving supply from ward to ward, sometimes from hospital to hospital. So that my understanding is that everyone had the PPE that they needed, but it was complex and challenging. And when I remember speaking to one of the nurse directors about, is there enough? He said, there is, but there's a palpable sense of relief when a new supply comes into the hospital.
I think you've mentioned that in your statement. Did you speak to people who were using PPE on the nursing floor and ask them if they had enough PPE?
So I didn't. We relied on our twice weekly meetings with the Health Workforce Directorate and the trade unions and the Royal Colleges to brief us on what was happening with PPE. And I think there's no doubt in the early days that the supply was not as good as it should have been, and it did cause anxiety. And because in my mind, not just clinicians, anyone who needs it should be able to put their hand out, get a face mask or a gown and put it on, and not have to worry about next time they go back to that, will there be one there? So there's no doubt early on in the pandemic, we would have been much better to have a better supply of PPE. There was one, so when you're asking me if I knew, that we had a system in Scotland. There was a single point of contact, and there was a Scottish Government email. And one of my colleagues emailed me to say, Fiona, I have this email. I wouldn't normally bother you with it. We'll deal with it. But because of what it said, I wanted you to know. And someone had emailed to say, I live near Fiona McQueen. I'm not getting enough PPE. And if you don't sort it, I'm going to go and knock her door. So They wanted me to know that, and they said, but they will sort it. I then spoke to the nurse director, and she said that they had more than enough PPE. So I don't want to say nobody ever alerted me to it, or everyone said there was plenty, because that wasn't always the case. But I was aware of anecdotal evidence, but it's my understanding that everyone who needed it got it. And once we were a few months in, there was a plentiful supply.
My lady, I would of course like to ask more questions, but that noise was my colleague setting the timer for me to tell me my time was up.
I did wonder if somebody was giving you a warning.
Albeit that I think there are many more questions that I would like to ask.
I think Mr Weatherby also may have some questions on this.
I'm
issue
obliged.
Too. Thank you, Ms Mitchell. Mr Weatherby.
Thank you. Can I just pick up then where Ms Mitchell left off? I asked questions on behalf of the COVID Bereaved Families for Justice UK group. And again, picking up on PPE. We heard evidence yesterday from the Scottish TUC of really acute shortages of PPE in the early stages. Now, you were represented on what was called the Workforce Senior Leadership Group, yes, weren't you? And that's a group which brought together senior leadership from the NHS Scotland, the trade unions, professional bodies and health and social care partners. Were you aware through that group, presumably whose one of its roles was this kind of liaison, were you aware in the early stages through that group of concerns about really acute shortages of PPE?
Yes, I was.
Yeah.
But as I've outlined to Ms Mitchell, so yes, I understand there was a shortage, but my understanding is that everyone who needed it got PPE.
And were you aware of shortages in hospitals, for example, the Glasgow Royal Infirmary, where the inquiry has evidence that it was running low of FFP3 masks in March of 2020? Were you aware of hospitals running short of masks and PPE at that stage?
Yes. So my understanding is, so before the pandemic came, that anyone who needed PPE and a supply of PPE did not have to think twice about going to the supply cupboard and taking it and using it. But once we increased the amount of PPE people had to wear, then stocks diminished. And at one time, for gowns, I think there was less than a full day's supply within Scotland.
Well, that's where I was going to head next. My lady, there's a crossed wire, I think, about my next question.
Just have it put up on screen, Mr.
Yeah. It's a question. Thank you. I'll be as quick as I can. INQ 000108737, and it's page 12, please. I think this, just while it's being put up, this illustrates the point that I think you were just about to make. Could we highlight the graph, please, at the top? Now, this is a report from Audit Scotland, a government report, and it sets out various pieces of PPE, and it's between April 2020 and May 2021, and the levels. And just from a brief glance at that, it appears that at the start of April, the levels of PPE were almost out, putting it briefly. Would you agree with that?
Yes.
Yeah, and were you aware of that at the time?
Yes.
Okay, and just very briefly indeed, what actions did you personally take to resolve those issues, if any?
So PPE was not, in terms of the supply of it, was the responsibility of National Shared Services, and it,
right.
However, that did not mean to say I did not have anything to do with it. So my DCNO was on these workforce meetings, and she would feed back to me. We would be assured by our colleagues, policy colleagues who were overseeing it, that they were doing as much as they possibly could to do that.
So effectively you escalated it and you were reassured?
I think I would go farther than reassure. I think I was assured. So evidence was given in terms of, and of course by this time there was an international demand. So yes, our suppliers were struggling to supply us. We needed to get PPE from different areas across the world, and that in itself was tricky. So although we thought we maybe have a 2-day supply and we know we're going to get 4 weeks supply coming in to Prestwick Airport from China, we until it was actually into us and through customs, we didn't know.
Right. And it just, again, in one sentence, if you can, is there a lesson here moving forward for the next emergency of this nature which will occur?
For sure. I think that whole, the management of PPE, so the rotation of stock, how much you have, looking at best and worst case scenarios, then I think there's absolutely no doubt that that is one of the key areas that needs to be addressed.
Thank you.
Subject to funding.
Okay. I've got a second topic, but I think you've probably dealt with most of it, so I'll be very brief indeed. You say in your statement that the Scottish Government's specific role was limited to the general promotion of NHS Scotland as a potential employment opportunity for temporary registrants. And my question was going to be why you said that. Is it right that you say there was limited because of your earlier evidence that in fact you didn't think the temporary registrants were in fact necessary?
So if I may take slightly more than one sentence to answer you. I think at the beginning of the pandemic, we didn't know. In fact, I thought we would have been much more overwhelmed than we were. We were looking at pictures of Italy and patients lying on ED floors, nurses becoming incredibly ill at work. So we didn't know what we were going to get, and we didn't know whether or not. So we needed to open all avenues so that we would have that supply. I think there are ways we could better utilise temporary registrants, I think, if we had a better system. Now, one of the things we did put in place from about May was we had a calculator of workload right across health and social care, so that we knew what the demand was and we knew whether or not there was a demand for workforce.
Okay.
And I think we probably could have done more to help the temporary registrants into perhaps social care or some other place that was struggling.
And you, my last point, you refer later to further preparatory work that might have been done. Does that relate to the point you're just making in terms of how you could arrange it so that temporary registrants could be brought onboarded and used appropriately?
I think most definitely, as well as looking at surge capacity and how we can keep practitioners who are not working contemporaneous in their practice.
And that's perhaps something that should be looked at going forward.
Definitely.
Thank you very much. Thank you, my lady.
Thank you, Mr. Withby. Very grateful. Mr. Wagner?
Yes, I'm all the way over here. Hello. My name's Adam Wagner, and I ask questions on behalf of 13 pregnancy, baby and parenting organisations. I've got 2 topics to ask you about. The first is about guidance in neonatal care. In November 2020, the Scottish Government added a line to the neonatal care guidance which said this: parents should be offered opportunities to remove face masks where it's safe to do so, to encourage bonding and support skin-to-skin and kangaroo care. And just to pick up on those final 2 words, is it right to say kangaroo care is a method of holding your baby to your bare chest, to allowing for skin-to-skin?
Skin-to-skin, so the baby would be bare and you would be bare.
Yeah. Were you involved in the changing of that guidance?
So I had another Deputy Chief Nursing Officer who was the Chief Midwifery Officer, and she would have developed that guidance along with the Director of Children and Families Directorate.
And do you have any knowledge of why the Scottish Government decided to modify the guidance in that way and add in that extra reference to skin-to-skin care?
So no, I don't, but my view is skin-to-skin care is an evidence-based intervention that supports physical well-being of a neonate as well as the emotional health of the parent.
Yeah, and so that would be why that exception was made to the mask wearing, that they could take their mask off because skin care was so important.
So it's so important. And by that time, we would have seen how the virus was operating. We would have been able to take, on balance, proportionate risks that we were not prepared to take earlier on in the pandemic.
Yeah. So on balance, proportionate risks relating to the mask wearing versus the benefits of skin care. The second area I wanted to ask you about is the wider restrictions that were placed on maternity services. And I appreciate you said that there was that you had a deputy who was responsible for that care, but may I ask you just a couple of questions about that overall point, because you do refer to it in your statement. So just by way of context, there's been a number of reports since the very early stages of the pandemic relating to the impact of IPC, infection prevention and control restrictions on maternity services. Are you aware that according to a 2022 report, perinatal depression, that's depression around maternity and birth, and anxiety almost doubled during COVID-19?
Yes.
You are. And are you aware of the statistic that's in the same report, that the rates of depression and anxiety amongst women who gave birth during COVID-19 were as high as 61%?
So I wouldn't have been able to give you the statistic, but I knew it was high.
Yeah. And then secondly, are you aware of there was an Embrace rapid report published in August 2020 relating to maternity services?
No, but I may know the topic if you remind me.
One of the findings that the report made, so it looked at March to May 2020, and it was published in August of 2020, and it found that 4 women who were pregnant or had recently given birth had died by suicide during that 3-month period. And the authors found that changes to the service provision as a direct consequence of the pandemic meant that women were not able to access appropriate mental health care. And it found that the receipt of the specialist care they needed may have prevented their deaths. Have you heard about those kind of issues arising?
I've heard about those kind of issues, not necessarily associated with maternity, but with wider societal issues, yes, yeah. Tragically. And
then thirdly, there was a study in October 2021 that concluded the re-establishment of face-to-face parenting support groups appeared to be imperative to postnatal emotional well-being and recommended the prioritisation of essential face-to-face healthcare visitation in the immediate postnatal period. Now, you may not be aware of the report, but would you agree with the sort of sentiment of that?
Yes.
So, in that context, I just want to ask you about your statement at paragraph 208, and I don't need to go to have it up on the screen, but you say there, whilst we recognise the impact the virus had on the more vulnerable in society, I wonder if we could have done more during the pandemic to support such groups. And you say, with hindsight, a number of measures may have been beneficial, changing restrictions to support new mothers to receive additional in-person support from family and friends. So with hindsight, can you give a bit of detail about what kinds of changes you would have made for new mothers?
So I'm going to repeat I have been out of healthcare for over 3 years, and therefore I don't have the benefit of the wisdom of having colleagues, but it's my understanding that a new mother could not have visitors. So I think being able to have your mum or your sister or a close friend or someone else coming in to help and support you would have been beneficial. So I think looking, and that, if we look at visiting in maternity hospitals, the real challenge there is if somebody is looking for additional support, then the balance is people who come in may have been bringing COVID, and then there would have been nosocomial infection right across the unit. So the balance there is someone's benefit could be harming someone else. Once pregnant women are home with their babies, or in the lead up to birth, when they're in their own house, then they can make their own decisions and take their own risks about the balance of having emotional support for their well-being versus the risk of COVID. And of course, they could then talk to whoever was providing them with that support and know that their behaviour was keeping them safe without COVID. So I think there are ways that we could have learned for how we could bubble bigger groups together to provide emotional support, or provided with social distancing classes or supports, because I know that in the postnatal period, if it had been, although you don't have to have a toddler to go to toddlers groups, you can have a brand new baby. There are many informal ways that people in society have support, and new mothers have there as well. So I think working with women to find out what was most distressing for them, and I think we know, but working to see what we could do, I think would be important, so that we know for the next pandemic, and it needs to be rehearsed and looked over, at ways we can mitigate and prevent some of the tragedies that have happened as a consequence of this pandemic.
I'm afraid you're going to have to leave it there, Mr. Wagner. Sorry. I think I've stretched the stenographer's patience to the limit today. Thank you very much indeed, Ms. McQueen. I'm really grateful to you. I hope your daughter didn't get put off nursing, did she?
No, she is thriving. Thank you.
Wonderful. Well, I'm sure it's a proud family tradition now. So thank you very much for your help. I'm really grateful.
Thank you, my lady.
10 o'clock tomorrow.